Okay, welcome everyone. So today we're gonna go over weeks 1 and 2 of your MSK module. And this, I want to kind of really pinpoint the high yield material that we found to be kind of consistent through and through this entire kind of experience of us doing OPLGs and weekend review sessions. Brady and Lindsay have kindly offered to do the second half of this for you guys, potentially next week or the following week, whenever you guys have before your next exam, they will definitely do it. This is specifically going to cover as much of the stuff that we remember and we saw was clinically significant. As always, this is not affiliated with the school directly. Obviously, we are all OPLG leaders that are doing this, and we've all kind of been vetted by the school, but this is not affiliated. We just do this out of the kindness of our heart. And if you guys have any questions, feel free to unmute yourself, ask those questions, and I'll do my level best to answer them. Okay, let's get the ball rolling. Here's the T is the session ID. Turning point is what we're using. Whenever we get to questions, I will activate the turning point session and you guys can click in your answers. Okay, let's get started. Awesome. Okay, so I run the Here's the T PLG page on Facebook. You guys are all likely signed up for it. So that's how you probably landed here. I also post on your guys' class page whenever you guys whenever we have potential review sessions. Here is the link to our group, just in case you have no idea what the heck I'm talking about. So the link to our Facebook group, it has access to cool resources that we found helpful. We've also compiled other resources as well as other DES pages that you guys can check out in your own free time and whenever you guys need additional help with anything. Cool. Okay. I don't know if I can say this enough. Do the Grace questions. I think everyone has this mindset, and this is a mindset I also had when I was kind of starting off term one, was how am I going to do these questions when all of it seems to be completely vague? It makes no sense. I feel like I haven't learned it enough to do these questions. But what you'll realize is you'll pick up patterns, right? You'll see patterns of which topics to study as compared to just going in blindly and not having any clue as to what is high yield, what is clinically significant, and how it's going to be asked of you, whether it's in a quiz, whether it's in the IMCQs, or if it's on the exam. Okay. Whenever I did Grace questions, I got wrecked. And I'm going to be honest with you, I prefer to give you guys the real deal. So I got wrecked plenty, but when the exam time came around, I did fantastic. It was great. It was a grand old time. There was a nice curve too, but obviously that's not always the thing that you guys need to look forward to. You guys should be working like this is a knowledge that you're going to put it into your mind. Okay, another thing to note is that anatomy and overall anatomy isn't the biggest thing that's on the USMLE step one, right? It's likely tested, but it's not the primary thing that they prefer to test on. So don't get freaked out if you don't do the most amazing job in MSK, like you're not like, killing it in terms of anatomy and physiology. They're going to constantly repeat this material until it becomes clinically significant and straight in your guys' head. So don't be shooketh by this, okay? Sorry, I had to open the chat. You guys have been messaging me. I'm not flexing. I try not to flex on you guys. This is a hard one. I'm going to tell you guys this is a hard module for a lot of folks, not only because it's situated right in between the term, but it's also when you guys are kind of like, oh, I'm in med school. This is a lot of work. This is kind of overwhelming me right now. So make sure you guys take some time in the weekend to kind of put yourself together, re-energize, and you guys can tackle this material for sure. Let's do this. Okay. Now, you guys know that you guys have a spinal column, right? Like this is the thing that helps you sit up and keeps you straight throughout the entire day. And when you lay down at night, it provides you like the arch supports and everything. So everything that you guys need to remember with the vertebral bodies is that there are 7 cervical vertebrae, right? 12 thoracic, 5 lumbar, the fused sacrums, there are 5 of them, and then the coccyx is 3 to 4, and they're fused. So we typically club the sacrum and the coccyx region together. So most of the times, anything clinically relevant is going to be tested from the cervical to the lumbar region. And you guys are going to see that time and time again. So don't be freaked out if they start asking you questions on this. Now, obviously, if it's basically the axis of your entire body, it needs to bear a lot of weight, right? Not only is it holding up your head, it's also holding up a majority of the rib structures, everything from your limbs to the lower limbs, et cetera, are all connected to the axial point, right? So it's under a lot of pressure. And obviously, with anything that's under a lot of pressure, you need to give it support. Now, the annulus fibrosus and the nucleus pulposus are your intervertebral discs that basically stop your two, vertebral bodies from colliding with each other and having a shearing motion and basically squishing the two structures together. Okay, that's important to remember because they really like these two for asking questions about the embryological origin. So you guys keep asking me like, what is the embryo stuff that I need to study? The critical thing that you guys need to study is like the nucleus pulposus versus the annulus fibrosus, right? The nucleus pulposus, what's its embryological origin, guys? Feel free to unmute yourself and respond.
Notochord?
Notochord, absolutely. Okay, that's one of the unique things. So keep that in mind. This is the part that actually does the disc herniation. Okay, it basically penetrates through the annulus fibrosus, which is a mesenchymal in its origin. It's going to cut through, and the spinal cord is going to be running through here, and it's going to start compressing it, right? And that's compression causes the classic presentation of any sort of herniation. Okay, any sort of disc herniation. Okay, critical to remember this one. I just threw that in here. I didn't give you guys too much details on it because all you just need to know is the embryological origin and the type of herniation you're going to likely see. Okay, let's do a question. I'm going to keep it short to like roughly 40 seconds per question, because we have a lot of material to cover. Okay, so what are we looking at? What we're looking at is, and majority of you guys got it. So we're looking at an intervertebral herniation between L4 and L5. Now, the reason I gave you guys this question because it's so often tested as to which nerve is actually likely messed up. Okay, remember the exiting point of wherever these spinal roots are essentially branching off of is gonna be tested, whether it's from the cervical region all the way to the lumbar region. They love those, okay? Now, L4 exits right before the actual discs tend to appear. So the next likely structure that's going to be damaged is going to be L5, right? The L5 spinal cord region is going to be likely messed up. So let me move this to this corner. So, okay, you guys know the amount of actual vertebral bodies that are here in each region and the spinal cord exiting points. Now, important thing to remember is that in the cervical region, everything exits above. So between C4 and C5, the C5 nerve shoots out, okay? Now, anything, at thoracic level, right? T7 to T8 is the example right here, is what's going to be shooting out is the T7 region, right? This shoots out below, right? Whereas the cervical region, everything shoots up above. Now, the lumbar region is very unique because the first thing that basically shoots out is the L4 nerve exits, right? Done. It's very simple. The next thing that actually likely gets compressed, right, with a disc herniation, it's going to be the L5, right? If you guys can keep this straight, it's going to help you guys a lot. Just do a lot of practice questions with it because sometimes they like to ask whether it's which nerve has exited, which one isn't likely affected versus which one is actually compressed or, damaged or et cetera with the herniation. Here it is. And if you guys see something repeating over and over, you guys kind of know like it's going to be tested very often. Okay. Now, I do this in here because this was a very unique thing. And whenever you guys have whiplash injuries, right? And whiplash is something that they've likely covered with you guys already. There are two likely ligaments involved. What two ligaments are involved with whiplashes?
The anterior and posterior ligaments?
Absolutely. The anterior longitudinal ligaments and the posterior longitudinal ligaments is likely the ones that you need to keep in mind. Now, why am I spending some time without giving you guys so much, craziness with this is the posterior longitudinal ligament is the actual ligament that bulges out and starts potentially compressing the spinal cord that's running through this area, right? Because what happens essentially, whether it's a whiplash injury or sort of disc herniation, this is very clinically significant. That's why I'm spending some time going over it. Okay. The disc herniates out and starts compressing the spinal cord. Now you're asking me, it's a ligament. Why the heck would it start, bulging out and moving out of place? The important thing with the posterior longitudinal ligament is that it's thick or dense or basically broader at the top, and as it gets closer to the bottom, right, more towards the bottom half of its kind of like division, it's going to get thinner, right? And as the thinness gets kind of present, the disc basically herniates around it and starts compressing the spinal cord. Okay, that's why it's clinically significant for the posterior longitudinal ligament. There's two things involved. One is a whiplash injury, and the other is, of course, a disc herniation. Okay, just to cover all the bases, the anterior longitudinal ligament is typically seen what type of whiplash injury, guys? When do you have it? Cervical, absolutely. Remember, is it like, does your neck snap back for the anterior longitudinal, or does it snap forward? Hyperextension, absolutely. You guys are saying it in the chat. It's hyperextension, right? It's basically when someone's head snaps back, the anterior longitudinal ligament likely gets damaged. Whereas if you hyperflex, the posterior longitudinal ligament gets damaged, okay? And we're gonna cover these in a hot minute when we do spinal taps, okay? Cool. Once again, I wanted to reemphasize this point. When you have the posterior longitudinal ligament, it comes down. It's basically dense right here. But if you see the disc herniation, it's going to come around the side of where the actual posterior longitudinal ligament is and start compressing the nerve, which is L5 here. Okay. Awesome. Let's do this question. I have a grand old feeling that I'm going to lose my voice by the end of this. It's going to be fun. Okay, I do see there's a question in the chat, but you guys are absolutely right. It's L1, L2, okay? Usually what we need to remember is that the level is safe because the adult spinal cord usually terminates at the disc between which of the following vertebral levels. For adults, it's L1 and L2, right? That's where it terminates. For children, it tends to be lower, okay? So whenever you guys are learning this, as always, keep in mind what is seen in the clinical practice can often vary, and it's all situationally derived. So got to be very careful, but remember, whenever you guys are getting tested, it's on SGU knowledge and what's likely going to be present on the boards. So keep that in mind. The answer is L1, L2. You guys were absolutely correct. Now, Important to remember is that in newborns, right, the spinal cord, right, terminates at L3. Okay, that's why when do we do, at what level do we do a spinal tap? Let's say we do, God forbid, have to do a spinal tap on a newborn. At what level would we do it? L4, L5. You guys are saying it in the chat. Absolutely. Okay. For adults, it's going to be L3, L4. Okay. That's just going to be the kind of the safety measure that you kind of have to, it's a nice margin of error that you can have. Now, why are we doing spinal taps at this level? Can you guys explain to me why we would want to do it at this level? Why? Because like you still have nerves coming down. Like, why are we not hitting one of these nerves and just basically, paralyzing someone? Less risk. Okay. Absolutely. Now, what you guys have to remember is that the cone, right, the spinal cord essentially ends at L1 and for adults, and L1, L2 area, and for children, L3, L4-ish area. Okay. Remember, that's a thick structure, right? That's the entire spinal cord. Everything else that comes down is part of the cauda equina, right? Cauda equina is basically the horse's tail, for fancy Latin peeps version of saying horse's tail, or how it looked like when they did the actual dissection. Remember, with these nerves, they're just basically floating in CSF. So when you're actually doing the lumbar tap, they're easily kind of moving out of the way, and you're less likely to actually puncture or hurt any sort of nerve that's coming down. So that's the reason why we do it at such a low level as compared to something higher up, where you have a very, very probably a guaranteed chance of hitting the spinal cord. Okay, you have very little risk when you're doing it right here, and you can still collect the sufficient amount of CSF that you need. Cool. That's the reason. Now, talking about spinal taps, and they love this question. Okay, I've seen it time and time again. There are two pops that you should hear. Okay, what's the first pop?
The ligamentum flavum.
Ligamentum flavum. Awesome. What's the second pop?
Dura mater.
Dura mater. Okay, if you guys have those two down, you should be solid on your lumbar taps. Okay, pretty much there 90% of the way. They're less likely to ask you guys about the other ones because you typically aren't going to go to that level of depth. And most of these things we really don't care about in terms of clinical significance. Ligamentum flavum, first pop, super critical that you hear that. Second pop, you've now entered this, past the dura, right? And you just have to go sufficient point, right, where you get to the subarachnoid space. Okay, the last pop wouldn't be the arachnoid. Okay, the reason why the arachnoid isn't actually getting the second pop, because it's not as dense, right, as the dura mater. Okay, so keep that in mind. Dura, second pop.
I have a question.
Yes.
How come the supraspinous ligament is not the first pop?
So the supraspinous ligament, depending on how you go through it itself, like you could either miss it because it goes in a weird kind of angle. It basically connects it in like a longitudinal line. It's hard to show this in like a 2D image. So if you guys have an anatomy app and you kind of like run through like your anatomy images, you're gonna quickly see like it's just basically stabilizing the spinal processes of the vertebral bodies, right? So that they don't just like fall out of whack and they basically slip out. So you don't want to slip disc either. So that's pretty scary. So these just stabilize the spinal column.
Thank you.
Yeah, no problem. And remember, these are all like things that they've kind of brought on from experience that they've kind of put into practice. The ligamentum flavum tends to be the one that you quickly hit because you would never go directly in between the spinous process. You typically, even if you're puncturing through, you're going to go slightly from the side. So first pop is typically going to be ligamentum flavum. Got to keep that in mind. Cool. Okay, this one is super, super simple. Kyphosis, right? You're going to have a slight curvature of what structure? Is it your cervical, thoracic, or lumbar?
Thoracic.
Thoracic, okay. What about lordosis? What is that going to be? What region? Lumbar.
Lumbar.
Awesome. Okay. And when are you likely going to see scoliosis? What disorder or disease?
Hemi something.
MS, polio, and there's one other, I think.
Yeah. The biggest
Hemizygous, hemivertebra.
hemivertebra is, I think, the technical kind of term that you could use to describe it, but the common one that I was looking for is polio. They love to ask you guys about scoliosis via polio. Okay, so just keep that in mind. That's a nice question stem right there. Okay, next one is a little bit about the spinal cord. Now, there's an entire module that you guys are going to cover called NB when you guys get to term 2. So I don't want to spend too much time on this because it's going to be kind of reiterated throughout the entire medical educational journey that you guys are going to have here. But I do want to go over a couple of critical points. Okay. Now, sensory is coming from what horn? The dorsal or ventral or lateral?
Dorsal.
Dorsal horn. Okay. Ventral is motor. Okay. So if you guys can keep that straight, that's pretty much your good chunk of the way there, because you're going to get into like an NB module. That thing is a Goliath, and you guys are going to have great fun with learning the entire details of this. Now, the dorsal horn is going to give off, or I mean, get innervation from the sensory kind of systems throughout your body. Okay. Now, where are they coming from? One, they're coming from the dorsal, well, I mean, they're going to come from the dorsal or posterior kind of rami, as well as the ventral ramis. Okay. When you guys are going to get those kind of sensory inputs, they're all going to be fed back to the dorsal root. And from there, they're going to send up into the brain and provide kind of sensory information for the rest of your body. Okay. Now, whenever they ask you guys a question about this, right, where are the cell bodies? Your immediate answer should be the dorsal root ganglia. Critical that you guys keep that in mind. Cell bodies are actually located at the ganglion, dorsal root ganglion. Okay. Now, if they ask you a question about the motor, where are the cell bodies of the motor kind of nerves, where are they going to be located? Target organ or ventral horn, since we're just at the spinal cord level. We're going to get into the target organ a little bit later. Okay. So as this is going from the ventral kind of horn, right, the motor component, it's going to go through and it's going to give off of 2 branch, right? One branch is going to go to the dorsal aspect, right? These are going to go to your back muscles. It's super critical that you guys remember that. They love questions about that, as well as it's going to go through the ventral system, 2 aspects of the muscle in your walls, as well as like the body wall, and as well as the limbs. Okay, typically the limbs is what they prefer, and this is just giving you a broad overview. We'll get into the actual brachial plexus in a hot minute. Okay, as always, sympathetics are going to be important. Parasympathetics, you guys are going to cover that in a little bit later in the next term, so we don't get too crazy with those. Sympathetics come from which horn?
The lateral horn.
Lateral, absolutely. Okay, so lateral horn, right, has the sympathetic complexes. So it's going to give the cell bodies are located there, and they're going to go through, right, from the ventral aspect. So they're going to hijack their way through the ventral aspect. They're going to first cross over using the white communicants, and then they're going to junction here at, what is this complex called?
Sympathetic chain.
Sympathetic chain or sympathetic ganglion, or however they prefer to call it. They're going to first meet up here. Then the second cell bodies are going to then branch out and give 2 branches that are going either to the dorsal aspect or to the ventral aspect. And now you're probably wondering, why do they have this loop-de-loop system from the white communicants to the gray communicants? Makes no sense to me. Now remember, the sympathetics are from what region to what region?
T1 to L2.
T1 to L2, right? That's critical for you guys to remember that. So all of the sympathetics for the entire body are only located at this region, of course, as well as the sacral region too, in a smaller kind of amount. But they basically give off the sympathetics that go up into other aspects, whether it's to further parts of your limbs or to your face or etc. So they go through that route. So that's why this ganglion or complex is needed, because some of the actual sympathetic nerves actually go up, some of them go down, and some of them actually cross over at the level that they're at. So that's why you have this kind of complex system of pathways, okay? So not to traumatize you guys too much, cervical plexus, right, is one of the plexus that you're going to cover in term 2. Brachial plexus, the lumbar plexus, and the sacral plexus, you guys are going to cover in MSK. And you guys have likely already covered a good chunk of it. Whether you guys, I think it's from even today's, you guys must have covered a good chunk of the lower leg components. So we'll go through those in a bit. Okay. Now, dermatomes, they love, okay? I'm going to make your guys' life very simple by saying this. Memorize these to the T, because we got tested on this till we basically finished with BSCE. We even got questions on the BSCE based off of dermatome levels, okay? Now, important to remember is they prefer certain landmarks, right? Now, where is the T for dermatome level? Nipple line, okay? They love that one. That is the defining band or dermatomal level that basically tells you where the rest of the lining systems are, whether it's T3 going up and T5 below, etc., so on and so forth, okay? Now, critical that you guys remember that, as well as what is the dermatomal layer for your thumb?
C6.
C6. And what about for your first two, after your thumb, what are your first two fingers?
You mean the pinky? C8.
C8 is pinky, but in the pointer and the middle
C7.
are C7, absolutely, okay? Critical that you guys remember that. They also like S2, 3, 4, and that's keeps the penis off the floor. That's a little mnemonic to kind of keep you guys, aware of which dermatomal layers are affected with any sort of pelvic level issues. Okay, let's do this question.
Sorry, you said that C8, I know C8 was the pinky. What was the other one for C7?
C7 is going to be the pointer, or the index finger, as well as the middle finger, right?
Okay,
These
thank
two.
you.
Let me open up the question now. You guys were probably wondering how they're going to ask you guys the dermatomal level questions. And this is a great example of it. So
I'm sorry, you said C7 was index and middle, correct?
correct.
All right,
And
thank
it's
you.
kind of split in half. It's halfway. So the middle finger, when you guys realize like the innervation systems, like you guys will realize it, like it's cut in half. And the nice thing is about it's a middle finger. So it's like one half of it is C7, the other half of it is C8. So
Thank you.
yep, no problem. Awesome, guys. Oh, question. I'm sorry, would you please state what neurons does the dorsal root ganglion hold? The dorsal root ganglion holds the sensory component, the cell bodies of the sensory component of your entire body. So important to you guys remember that dorsal root ganglion, cell bodies, and the nuclei of those sensory components. Now, the answer here, as most of you guys put, is the dorsal root ganglion of C7, okay? Nicely done. It's sensory. And this is a very important, I hate to say this, don't learn it based off of buzzwords, but shingles tends to be the dorsal root ganglion, and it primarily affects the sensory location, okay? So keep that in mind. You're gonna learn a lot more about shingles when we get to term 3. And I have full faith that you're gonna get to term 3 and you're gonna kill it, okay? Cool. Important dorsal root ganglia of the spinal nerves. You're going to learn about the trigeminal, the geniculate region of the facial stuff when you guys get to term 2. A lot of this is going to continue to expand, and you're going to see this time and time again. So this is how they like to test the dermatomal levels. So let's say someone has this kind of presentation. What dermatome do you guys think is likely affected here?
C4.
T4.
T4.
C4, this is the nipple line right here.
T4.
T4. Okay, so T4 right here, right? This is likely going to be T3 or T2. The bands are kind of hard to distinguish when you're looking at a real person, and that's why there's a little bit of margin of error. So typically, in order to get the full presentation of shingles, it tends to be 2 or more kind of dermatomal region. So it's going to be, let's say someone has an issue at, let's stick with this example, at T3. Let's say this is T3. So what's likely going to be messed up is both T3, likely a little bit T4. So you're going to see like slight spotting here, as well as slight spotting above, okay, which is T2.
Does the T4 level also apply to like, no matter how big your breasts are?
Yes, it doesn't matter. The innervation systems still kind of go in a band-like pattern. Some people call it strip-like pattern, but like it's like a band that kind of wraps around you. So it's going to be consistent through and through, regardless. That's at least that's what we were told when we went to small group and everything. When I even had that question too. So definitely stick with T4. Use the nipple line as your guiding point. Okay. They also like this random tidbit of a one, which is the tip of the xiphoid. Now, can someone like basically pinpoint where the xiphoid is, so that you guys are all anatomists now, so we're gonna figure out if you guys know where the xiphoid is.
Isn't it like underneath the sternum, like at that point?
Yes, it's the tip of the sternum. A lot of people call it like the solar plexus. Like you basically, if you hit it, and you could basically hurt someone because a lot of different organs and systems are in that general region. So T7 tends to be a nice one to remember too. Okay, T4, T7, they like that one. T10, the umbilicus tends to be a good one too. That's also another landmark one, so keep that in mind. Basically, if you see any one of these are your guiding landmarks. And if you know these, you're going to be solid. Okay. Awesome. Let's do this question, a little bit of embryo, since you guys were asking me how they're going to test embryo. Awesome. The session ID for the turning point is also here if you guys need it. So feel free to sign in, punch in your answer. Awesome, guys. Exactly, remnant of the pluripotent primitive streak. Now, this is a very unique thing because the pluripotent streak, right, essentially gives rise, and it tends to be the caudal region. It doesn't appear most other places. What's the diagnosis for this? What do you guys call it?
Sacrocegeal teratoma.
Exactly. And that tells you the region or the presentation or likely the place it's going to appear. It's a sacrococcygeal region and it's a teratoma. Now, the teratoma is very unique because this pluripotent stem cell, right? The stem cells here, they can turn into a whole bunch of things. So when you have a whole bunch of things appearing, they can have all sorts of different germ layers. When you have all sorts of different germ layers, when you actually excise this out, and there's some gnarly pictures on Instagram, you basically have teeth. You can find hair in there. You can also find muscles and glands. It's kind of freaky to think about, but this structure has so many different kind of potential derivatives, so keep that in mind. Okay, a little buzzword to kind of put that into perspective. So pluripotent primitive streak. Let's do this question. Yeah, you guys can tell my whole Instagram algorithm is messed up. It's all just medical knowledge. Yes, are the cell bodies of the motor neurons found in the ventral horn? Correct, they are. And they do have a little bit of degree, and you're going to get more into it when you guys get into term 2, how the actual innervation and systems happen with local kind of muscles and regions. I think someone even directly messaged me about that too. Give you guys a couple of more seconds since I was yapping away. Okay, so this is a spinal cord defect. Okay, can we all agree on that? It is. Okay, so what's basically presenting is the spinal cord, right, as well as the meninges from the defective lower region. The likely diagnosis is going to be a spina bifida with myelomeningiocephaly. Okay, now we'll go through this and I'll kind of tell you guys what is typically given to mothers before they're, even attempting to have a child or when they're pregnant. What is high levels that you want to give to avoid neural tube defects?
Folic acid.
Folic acid, absolutely. It's when you guys get into term 2, they're going to cover B9, vitamin B complex family of vitamins. Folate is B9. If they also ask you guys based off of vitamins, B9. Okay, cool. Folate is not B12, by the way. It's B9. Cool. Now, let's go through the different spina bifidas. Important, as the word gets bigger, it gets more scarier. That's how the term above us taught it to us, as well as Brady and Lindsay. They had a kind of a nice, quick way of remembering it. Obviously, if you guys want to know what meningiomyelocele is talking about, it's basically telling you that the meninges are present, right? That's the meningio aspect of it. Myelo is talking about the actual nerves or structures that are likely found in this region, as well as the cele is talking about the CSF or cerebrospinal fluid. Okay, bigger the word, the scarier the likely diagnosis is. Okay, meningiocele is just the CSF and the meninges. Meningiomyelocele is the nerves as well as the CSF and meninges. Okay, the most benign version of all of them is, of course, spina bifida occulta, and the kind of a buzzword for that is dimpling with hair. Okay, if you remember that, you're solid. You're going to quickly identify the spina bifida occulta. Okay, now the worst version of this is called what?
Ashesis?
Yes, and that is a complete opening at this level. And remember, there's a kind of a surgical kind of term for this. Whenever the nerve is exposed to air, there's a likelihood that it's never going to likely grow back, right? Or it's going to be permanently damaged. So it's never a good thing. Infections and other things can kind of get into it because it's an open wound technically. And any sort of infections can then proceed to go into the brain. So very poor prognosis with that level of spinal tube defects. So just keep that in mind. It's a likely thing to kind of occur. Okay. Now they didn't spend too much time with this, so just keep that in mind. We're going to cover a lot more of this when you guys get to NB, which is neural and behavioral. So the central nervous system is composed of these main things. You guys know that very well, even from your undergrad: brain stem, and the spinal cord. So whenever they're talking about the central nervous system, it's going to be these 3. Whereas the peripheral nervous system is going to be all of the somatic innervation, motor aspects, the preganglionic, visceral kind of sensory components, as well as the motor. Okay. Now, neural crest derivatives, you guys got to be very solid with this. Sympathetic and parasympathetic actually come from the neural crest, right? So that's a very unique thing. Keep that in mind. They like those, as well as the leptomeninges. We're talking about the pia and the arachnoid. So whenever you're talking about the dura, it's different, whereas the leptomeninges here, it's going to be pia and arachnoid. They love those. Okay. Let's do this question. Also, no worries if you guys need to hop off at any time. This is going to be recorded and it will be posted. All right, what's the diagnosis, young doctors? And you guys killed it as usual. So the answer is spondylolisthesis, okay? Now, why is this the case? It's just the anterior dislocation of the body of the L5 vertebra upon the sacrum, okay? It's just moved forward slightly, okay? It's not a big old lysis, okay? Whenever you see lysis, think about like cell lysis or anything like that. It's a broken thing, right? So keep that in mind. So whenever you guys think of your spondylolysis, listhesis, etc., think about the Scotty dog, okay? And this is like a little British dog and it's really cute, but remember here, it has its neck kind of broken. Obviously, no dogs were harmed in the process of doing this. Important thing to remember is that what is broken here?
Is it the
The
neck?
The
parainferalis.
pars interarticularis.
The pars interarticularis, okay? So those are articulating points between the two. I mean, obviously, like it stabilizes the spinal column. So as you have the interarticulating points kind of broken off, they can then freely move about. So sometimes you can have spondylolysis with listhesis, right? And there's a kind of a big old term for it, and I have a terrible time pronouncing it, but it's a great way to test both concepts. So just be aware when you see a Scotty dog plus a anterior moved kind of spinal column, then you have spondylolysis with listhesis. Okay, so here you have a straight old normal presentation. How do you identify it? Quickly identify the Scotty dog. It has a nice little cute little appearance with its tiny legs, and one like the neck is completely fine here, whereas the more lower aspect of it has this broken neck, right? And you can see it. This is a straight up classic presentation of the lysis. Do you see any sort of anterior movement? No. So it's the pars interarticularis broken. There is no kind of moving forward. So it's just spondylolysis by itself. You can have spondylolysis with listhesis, right? You can have broken and as well as moving forward. And that's a kind of a bigger kind of diagnosis. So you guys can, whenever you guys are going through the actual exam, what I did is just trace it down with my mouse and see if there's an anterior kind of movement, and then picked my answer based off of that, because you guys know definitionally what it is, but all you have to do is confirm that it's either a lysis or listhesis, or it's a combination of both, and you guys are going to be completely set. Cool. Let's do this question. Just a friendly word of advice. Whenever they give you guys a DLA on any sort of imaging, it tends to be high yield because they can add clinical correlates right above it and they can test it. So they can be like, okay, like this thing, this MRI is given, what is the likely diagnosis or what has gone wrong? And it's a quick way for them to give you a second order question. Awesome. Okay. The answer is the transverse ligament of the atlas. Now, this tends to be, for some reason, it trips up a lot of people. I'm a big Greek mythology fan. So how do you guys tell your difference between your atlas versus axis?
Atlas rules the world, so he's on top.
Correct. So Atlas actually holds up the world so that your head is basically everything that you are, right? So he holds up the world. That's C1, whereas your axis is C2. So if you guys keep that straight, it's going to help you a lot. But the critical thing that we're focusing in on here is the transverse ligament of the atlas, okay? This basically stabilizes the dens that you guys correctly chose of the odontoid process. Okay, so this is C1, right? You guys can see the type of damage that's happened here, right? With the different type of odontoid fractures. Now, why is this bad? Why are we kind of focused on this odontoid process kind of being broken and bad? Exactly. It compresses the spinal cord. Absolutely, guys. And if you have any sort of, think about it, if you start compressing the spinal cord, it's a complex of nerves. And if the nerves get compressed, you're going to have broad gauge kind of presentation of both your upper limbs and lower limbs being affected. So you don't want any sort of thing. Now, in terms of severity of this entire kind of fracture, type 1 is relatively okay, right? It's unstable, but you can potentially fix it. But type 2 is worst off because it's basically a big piece that just lobbed off and now can freely float and start compressing things, right? Within CSF and then spinal cord. Okay. Type 3 isn't too bad because it's the best prognosis for healing. It's basically how I like to think about it. It looks like a puzzle, right? It's a perfect cutout of where how the atlas is. So once you have that, it basically, or sorry, not your atlas, your axis, it has basically that division, right? And it basically slots in nicely so it doesn't move around too much. As compared to here, it's a free moving piece of your C2. Once again, I just want to correct, it's a C2, right? Not your atlas, it's your axis. Cool. I threw these in here because not a lot of folks focused in on this and they missed 1 or 2 questions on the different types of fractures. So just be aware the kind of typical presentations of like the hangman fracture versus the Jefferson's burst fracture. I'll go through these if you guys want, but let me know if you guys need kind of clarity on these, but I threw this in for completion's sake. Okay.
Could you run through it real quickly?
Could you do just a quick run?
Yeah, of course. So hangman's fracture, we're talking about likely a C2 axis level damage, right? You can see how this has an off angle right here. That's because this is a hangman. They used to hang people in the back in the day. And then, obviously if you have potentially someone with a, who comes into the ER, they've tried to commit suicide, and it's a very, tragic, but if you had to take an x-ray and they're still alive and everything, you got to make sure that the C2 and their spinal column is nicely stabilized, because this can really mess up C2 and C1 particularly. But whenever you guys are thinking hangman, think C2, okay? C1 tends to be Jeffersonian burst fractures, okay? Now, this is a classic kind of thing. If you guys play football or anything, and I personally didn't, although I did work with football players when I was a kind of a student athlete kind of trainee, they have folks who basically, they would they would tackle with their head down, and this is a common way that they can have a Jeffersonian burst fracture, and this is super hard to resolve, because think about it, this is C1, right? It's very much close to the rest of your body, or sorry, not your body, but your brain. It's the first thing. So whenever you have a C1 level fracture, the prognosis tends to be poor and it can really mess you up, because it's a compression level fracture and it can mess up and likely tear the transverse ligament as well. So very poor prognosis. You can have multiple fractures of C1. Okay, now compression fractures are a little weirdly named. There are 2 types of compression. You can either have a wedge, right? Wedge kind of compression fractures can appear based off of the weight that you add to it. And it basically causes a wedge, right? Like it's a little, like a wedge that you would keep the door open. And that's a common thing that you would see with scoliosis. Whereas compression fractures by themselves are commonly seen with someone who's been carrying backpacks, or like, that have had a lot of weight pushed down upon them for a long period of time. So compression fractures tend to be like a long-term kind of issue. So a lot of military army folks tend to come with that, because they train with heavy equipment, and that over a long period of time that they've been keep on carrying it, they can present with compression fractures. This can cause disc herniations and all sorts of other things. Burst fractures, most commonly seen with straight up trauma. So we're talking about multiple shatters to the spinal column, and it's not good. Hard to repair. You have to go in very quickly. You got to stabilize the patient and repair, typically with the orthopedic surgeon. Okay. Cool. Hangman is technically a hyperextension, so they could ask you a question based off of the ligaments as well. Okay, keep that in mind. Let's do this question. Hyperextension of the anterior longitudinal ligament. Okay, that in mind, they can combine those two. But typically, you're more concerned about the spinal column itself because you're breaking some bones. It tends to be more scary. Okay, you guys were split. No worries. The correct answer is semispinalis. Okay, capitis. Now I'll tell you guys an easy way to remember this because what you need to remember is that these are your deep-seated stabilizing muscles. Okay, what they help the spinal column do is just align and keep you upright and functional, right? That's the general function. They do have an important role in extension of the neck and the thoracic and spinal column regions. Obviously, it stabilizes the spine, and overall their function is to stabilize, keep you erect and alive, okay? Otherwise, you'd be like loose and floppy and it'd be kind of sad, okay? Erector spinalis muscles, important to remember this. I love spinach is the nice, clean mnemonic to keep this in mind. And we're starting at the most lateral aspect. So we're going from iliocostalis to longissimus to the spinalis, okay? I love spinach, okay? Some people, for my carnivores out there, I love a steak, could also work, whatever floats your boat, okay? I'm vegetarian, so I put spinach in there just for funsies. Okay. Now, these are the superficial back muscles. Important that you guys remember this because these muscles weren't the highest yield, but they're often asked about in terms of reference to other things, right? Other common presentations. So make these tables, utilize these tables very much because they helped a lot kind of summarize an entire giant lecture into one table. Okay, now the muscles to focus on are the muscles that I put here. Okay, the trap muscles tends to be the most common thing that they love to ask about. What's the innervation of them? Spinal accessory nerve, exactly. Okay, critical to remember. They get sensory input from your cervical plexus from C3, C4. Okay, not super tested because you guys are going to cover that in another module, but they like the motor aspect, especially with like raising your arm and trying to brush and like your traps get kind of messed. If your traps are messed up, you're not going to be able to raise your hands up and brush or comb your hair. That tends to be a kind of a buzzword kind of stem thing. Latissimus dorsi, it's a giant honking muscle that goes all the way from you guys don't need to know the insertion origin points of these, but obviously it makes up the lower portion. It's a common muscle that gets weak and destabilized if you don't work out a lot or if you just keep sitting for a long periods of time. So keep that in mind. The latissimus also gets very big whenever you do those lat pull-ups, okay? Traps also and your salt will come for brushing your hair too. So keep both the traps and the salt, serratus anterior and everything for your kind of brushing your hair thing, okay? Now, your rhomboids, the R and R go together. So a rhomboid major is actually located below, okay? That's the first thing that kind of confused me when I went through this. Rhomboids are below, rhomboid major is below, rhomboid minor is above. And this is just regionally they're named rather, sorry, they're not named regionally, they're named based off of the size of the actual muscle, major versus minor. Remember, the dorsal scapular nerve is a branch off of the dorsal root rami. right? And that helps you guys kind of put this into perspective how the innervation system kind of works. They don't test as much about the blood supply for these because you don't have too many issues with your back muscles unless you got some multiple serious trauma. At that point, there are other big organs to be more concerned about rather than your actual muscles in that given situation. Okay. Trap, spinal accessory. Okay. Levator scapulae is C3, C4, and dorsal scapular nerve. Okay. Rhomboid major, minor. Keep those in mind. These are really nice. They do ask you about certain unique things. I'll cover those when we get to it, but rotator cuff muscles. Okay. What's the mnemonic for remembering your rotator cuff muscles?
Sits.
Sits, absolutely. Okay. Supraspinatus, right? It's involved in the abduction, right? Of the arm up to 15 degrees. Your infraspinatus, lateral rotation, teres minor, and the subscapularis. Now, what is the test that we usually use to test your sits muscles? We do the empty can test. Okay. That tends to be a very common buzzword thing. It tests more specifically your SIT. Okay, less of the subscapularis, but it tends to be the first three that they like to test with the empty can. Okay, cool. We'll cover the innervation when we get to it because these are good because they tend to be a common kind of presentation with any sort of brachial plexus level trauma. And I know you guys have plenty of trauma with brachial plexus already. This is what I was talking about. Okay. Back in the day, we had very poor stethoscopes apparently. So what we do is we look for little angles or pockets to basically assess for your respiratory movements as well as your bowel movements, essentially for any sort of like hernias and etc. So that's why we have both the triangle of auscultation as well as the triangle of petite. Okay, the triangle of auscultation, this one is a good one to remember because the medial border, they ask based off of the bordering, right? They know that you guys know where it is, but what they're going to test you is specifically like, okay, medial border, what is the muscle or bone or something that's located there? And they're going to be like, okay, can you guys tell us if it's a trap muscle, if it's a scapula, or is it latissimus dorsi? Quick and easy way to ask you a second order question with that. As well as the triangle of petite. This was a quick way to assess for any sort of herniation, as well as you can auscultate this point too, and hear any sort of like bowel level kind of movements and sounds. Okay. Boundaries is going to be the inferiorly, the iliac crest, anteriorly, external abdominal oblique muscles, and then posteriorly, your latissimus dorsi. Okay. And the floor, internal abdominal oblique. Okay, clinical significance, it can herniate because it's a little open pocket. If there's any sort of herniation of the actual, of your colon, it can kind of pop itself in there, okay? Okay, let me make your guys' life super simple, okay? When you guys are learning this, okay? Yes, you go based off of the margins. If you guys know the margins very well, you guys are gonna be awesome for that, okay? For your basically posterior scapular spaces, the quickest way is to throw up this gang sign, okay? Now that is gonna make your life super simple because that basically sets up the two triangles and one quadrangular space that you need to remember, okay? The first triangle that we're gonna focus on, and it's the one that they don't focus on that much because there's only one thing that runs through it, which is the circumflex scapular artery. Now, why is it clinically significant? Because it provides an anastomosis blood route for any of your vasculature if there's any sort of occlusion. They don't like to test that in that sense. They prefer to just ask you guys what is another artery that's going to give blood supply to the upper limbs, and they can ask you like circumflex scapular artery is one of them. So that's a good way to test that region. The quadrangular one is super important, okay? Whenever you dislocate a shoulder, okay? If you've ever seen a movie, right? Anytime that someone goes through trauma, they always pop a shoulder back in, okay? The way they ask the shoulder dislocation is how does it commonly present? It's anterior and inferior, right? They're basically, their shoulder just hangs out. It's gonna present like a box-like appearance. If you guys remember that box-like appearance, it's a very common buzzword, okay? What ligament is messed up? acromioclavicular, whenever you have a shoulder dislocation. What are the structures you're likely damaged? Axillary artery, posterior humeral circumflex artery. Okay, those two, squaring, exactly, squaring or boxing. It's the common kind of buzzword for that one. Okay, axillary nerve, you got to know it very well, not only based off of the brachial plexus, but also based off of this posterior scapular space. Okay, now we get to that slightly more important, which is the triangular interval. Okay, remember there is a triangular space and there's a triangular interval. Okay, the triangular interval has the radial nerve, right, as well as the deep brachial artery. So if you have, for example, how they like to ask this, not only in the Gray's questions, is a big guy comes in, he's been doing a lot of tricep workouts, because one of the two things, right, that we need to focus on is the long head of the tricep. The tricep has several different heads, right? There's the long head and the short head, okay? And those, where they insert to is important, but more so is that this space can quickly get compressed when you overwork out your triceps, okay? So obviously the radial nerve gets compressed and they're going to have poor issue with kind of like properly having any sort of radial nerve distal function kind of messed up, as well as your deep brachial artery slightly occluded. So they're going to have like numbness or tingling because the blood supply isn't as good as it should be going to the lower limbs, or not lower limbs, but the lower portions of your upper limb. Okay, cool. Any questions there? Let me guys show you guys the trick again. So you basically draw up this little sign. Okay, that sign tells you the different spaces, because you can see a quadrangular space in this quadrant. You can see the triangular space right here, and then you can see the small little interval over here. Okay, based off of that, you can say this is the teres minor, this is the teres major, right? And then this is the long head of the tricep, and then this is the actual humerus, because the middle finger is nice and big, and the humerus is a nice big, bone. So keep that in mind, and you guys can quickly identify the two kind of important structures on both sides, whether it's the teres minor, major versus the long head of the tricep and the humerus. Okay, this one doesn't come up too much because they really shuttled it more into your CPR unit, but I still want to cover it because it gives you a broader perspective and they could potentially still ask this question. Which is the branches of the aortic arch. Okay, you're like, why the heck am I learning about this entire blood supply in MSK when I need to learn about it in CPR? That's likely the reason that they shuttled it. But important to remember are these, because they give blood supply to the scapular region as well as your upper limbs. So we're going to go through them. Okay, these are the branches and how you can remember them: vitamin C and D. Okay, and doesn't stand for anything. I could have just used the and symbol, my bad. But V stands for the vertebral artery. Okay, this one goes into the vertebral segments in the cervical region and gives blood supply and branches off into, you guys are going to cover that in a different module, but it's going to give blood supply to the brain in two separate divisions, as well as your facial muscles. You are then going to cover the internal thoracic, right? This goes downwards and branches and gives splits off into like versions that go into the thoracic wall. Okay, basically there are muscles in the thoracic wall that allows you to kind of expand and contract, and as you're doing your breathing. Obviously they need blood supply, so internal thoracic is going to give like offshoots that you're going to kind of see. So there's like two different sides of it, right and left. Okay, and then you're going to get to the T, which is the thyrocervical trunk. Okay, break apart those words. Okay, thyro is talking about your thyroid gland, okay, which you're going to cover in a different module, but cervical is talking about the cervical region of your spine. So you guys can kind of identify where this trunk is going to give blood supply to, the thyrocervical muscles that are in that region, as well as the posterior aspects of your neck. Okay, and then finally we get to the costocervical. These two kind of anastomos, right, and give blood supply to that entire kind of neck region. So we won't spend too much time on it because you're going to learn about it later on. And then you're going to get to D. This one isn't often seen. This is, I think, the dorsal. Sorry, I forgot what the D one stands for. Can someone correct that for me? What is I always forget that one because it's not commonly seen in most folks because this
It's
blood
dorsal
supply.
something. I just can't remember, but it does start dorsal.
Yeah, it's like dorsoscapular. It's often not seen in most folks because it's one of those like very unique anomalies with most individuals like not having it. They basically just get the vitamin C. They don't get the vitamin D component of it. So you guys don't have to worry about vitamin D component of it. I think it's dorsoscapular. So don't quote me on that. Double check. And I have a link out to external research that you guys can use to kind of verify all this stuff. Yep. Let's do the next one. Okay. Now, obviously, we talked about the branch. Okay. We've done the branch. Now we need to know the subdivisions that are going to the upper limb. Okay. Important thing to remember, this little mnemonic is 60, scene, love, sex, and pot. Okay. The dirtier the mnemonic, easier to remember. That's always my philosophy. So what does it stand for? As you guys cross your first rib, right? The first rib is up all the way up here, right? You cross that first rib, it then becomes basically your, I mean, it hasn't become your axillary, but it gets into, well, the brachiocephalic. And after the brachiocephalic kind of divides, you're going to get into the axillary component. So the actual axillary artery kind of starts here. Dorsoscapular. Cool. Glad I remember my MSK knowledge well, even though I hadn't written it down. It's an exception, not the rule. So just keep that in mind. If they ask you about the dorsoscapular, it's not often seen. It's almost like a vestigial structure on most folks. But let's focus on this. The superior thoracic is what S stands for in the 60s. T stands for the posterior aspect, and it gives way to the thoracoacromial kind of divisions, which is cadavers are dead people. What does cadavers are dead people stand for? It's the clavicular branch. A is for the acromial branch, and then P is for the pectoral branch, and D is for the deltoid branch. Do you guys see how it's useful to remember this based off of like the blood supply? Because it tells you exactly where it goes as long as you remember the mnemonic, okay? So keep this, it's a very straight up memorization thing and you guys are gonna be good. Then you're gonna get to, I mean, the lateral thoracic is L for love, and then S is gonna be the subscapular, and then P is for the posterior circumflex. That's the major one. The anterior circumflex, they don't really spend too much time covering. The posterior circumflex humoral is the one that goes through what space, guys? Called posterior humoral circumflex. It goes through the quadrangular space. Quadrangular space. Nicely done, guys. Important to keep that in mind. This is how you guys can learn it. Put concepts together, make it into a roadmap, okay? Awesome. Okay, I'm gonna save you guys a whole amount of time trying to memorize all of these. When they ask you guys questions about the scapular anastomosis, they're gonna ask you based off of one simple thing, right? Which provides the anastomosis if one of the major vessels is occluded, and the answer is always gonna have the word S or scapular in it, and you're gonna get the answer right 99% of the time, okay? It's either gonna be dorsal scapular, and it's either going to be circumflex scapular or the suprascapular, okay? If you remember these based off the scapular term, none of the other answer choices typically have those, so that's the way you're going to get the answer. Kind of quick, short, easy way to get a few points on the exam. Let's do this question. How are you guys holding up? You guys want to break in a bit? I'll give you guys a little 2-minute, 3-minute break because we have a lot to cover. Put it in the chat if you guys want to break. I did build in a break at like a 100 slides mark, but I can give you guys a break early on since I covered a lot already. Yeah, I know today was a long day for you guys. I didn't want to do it over the weekend because there's so much that you guys are gonna have to cover. especially whether you guys are going to get caught up or trying to read ahead. I don't want to run through too much of your time. Or like a long week. Yeah. Wait, you guys don't have Monday off, right? My bad. I technically, in my head, I'm like, you guys get Memorial Day. No, you guys unfortunately don't. Okay. You guys were absolutely correct. The answer is the acromioclavicular ligament. Okay. Now, let's go through these. So, and I'm a firm believer during the exam, don't do this, but for now, in order to commit to memory, the different kind of divisions of the scapula you can kind of identify, okay? First, follow with me. When you guys poke right here, right, you're gonna feel like, basically if you palpate around, you're gonna feel like a ball-like structure in the anterior aspect of your arm to kind of shoulder area, right? That is your coracoid process, okay? The coracoid process has a ligament that goes and connects to the clavicular portion, right? That basically stabilizes the clavicle in its location. Remember, the clavicle is just basically held together by a couple of ligaments, and they are basically anchoring it to the shoulder, right? To the shoulder, and basically anchoring the rest of your lower limb, not lower limb, your upper limb to the rest of your body, okay? Now, the second aspect that you guys are going to palpate is the acromial process. So if you guys basically go up from the coracoid and you make your way and you feel your clavicle and it turns into this little ball in the back, that is going to be your acromial process, right? It's a little kind of, once again, a little ball or structure that protrudes out, and you're going to feel that, okay? Between these, right? Between these 2 points, between the acromio and the clavicle, there's going to be a stabilizing ligament, and there's going to be another stabilizing ligament anteriorly, which is the coracoclavicular ligament. These two basically attach and anchor the clavicle in your shoulder, okay? Now, when one of these separates, right, one of these torn or via trauma or anything like that, it basically dislodges, right, tears, it pulls the clavicle up. What pulls the clavicle up? It's going to be what structure, guys? What muscle? Give you guys some time. Levator scapula is a good guess. It's actually a sternocleidomastoid, okay? Your sternocleidomastoid, right? SCM, like you guys are saying, SCM, it connects your clavicle all the way to the portion of your, I mean, it's sternocleido, so it connects a portion of the sternum as well as the clavicle to your mastoid process in up here, right? It's another one of those things that allows you to take like deep breaths of air in. Like whenever you guys try to take a deep breath of air in, you're using accessory muscles right here to inspirate even more than what you're used to. So SCM is critical, and that's why it's a nice strong muscle, but the ligaments here are stabilizing it and not allowing for the clavicle to be pulled up. So that's how you guys can kind of remember the functions of these ligaments as well as the muscle that's likely going to pull it up. So this is a shoulder separation. Okay, it's going to kind of, they're going to look weird. Do you guys see this weird outline where the clavicle is basically protruding out of the person's kind of shoulder location? So whenever you kind of see this kind of weird notching right here, then you know that their shoulder has been separated. One of these ligaments is either torn or damaged. Okay.
I have a
Now,
question.
yeah,
Sorry.
go for it.
Will the vignettes ever say like step deformity for shoulder separation?
Yes, step is a good one to remember for that one. Definitely. It's going to look like a stepwise function. So you're going to see like, basically it looks like kind of like stairs. So.
Okay, thank you.
Yeah, no problem. They try not to give that one too many times because it's very, very obvious, but stepwise, it's going to be a good one to remember for definitely those ligaments being torn. Okay. Now, sits muscles, I put this in here as well as your arm abductors. Now, these aren't the exact ones that SGU gave, so go based off of SGU's numbers. Don't go based off of first aid, I beg you, because it's going to make your life so much simpler, because they're going to give you their numbers. But if you remember this, supraspinatus, deltoid, traps, and your serratus anterior are all involved in raising your arm. Okay, this is abduction, right? Not adduction, abduction. So buzzword, very, very buzzword heavy, okay? When you can't comb, what two muscles is likely damaged? comb your hair?
Is it serrated?
Serratus anterior, exactly.
Oh.
Serratus anterior, or it's going to be your trapezius, right? It's either going to be the accessory muscle that's likely damaged or the long thoracic, okay? The quick mnemonic for remembering serratus anterior is going to be SALT. And I asked you guys a daily question of the day on this, but keep that in mind. They love to ask about this. Obviously, I also threw in the sits here, so just keep that in mind. It's going to be another one that they can use because supraspinatus is involved in starting the abduction process. Okay, cool. Now, before we do brachial plexus, I'm going to give you guys a little break and we will pick back up in 2 to 3 minutes. Okay, I will pause the recording right now. Okay, brachial plexus, the dreaded thing that everyone fears. Okay, but the exam isn't going to ask you guys to draw out the brachial plexus. It's going to ask you based off of damage or how it's going to likely show up in terms of clinical presentation, whether a nerve or a root is messed up or a rami trunk division or something's messed up. They're going to ask based off of that as compared to just purely like brachial plexus. Tell me like what spinal level is likely messed up. So just keep that in mind. Don't sit there and memorize it for the sake of memorizing it. Learn it based off of the clinical presentations. Okay, that's my general advice for you guys for the brachial plexus. But let's get started. Now, how can you remember the different kind of overall organization of the brachial plexus? The mnemonic is real Texans drink cold beer. Okay, roots, trunks, divisions, cords, and terminal branches. Okay, now obviously you guys know that brachial plexus is C5 to T1. Okay, if you have that straight, it's basically setting you up for what parameters you can kind of work off of. Okay, so let's do a question to kind of kick off where your guys' knowledge base is with the brachial plexus. This is a tough one. Let's see how we do. Guys are killing it, 66%. I can work with that. Okay, so the answer is B. Okay, what is the diagnosis, young doctors? It is Herb Duchesne's policy, right? Now, what is this kind of appearance that the baby's having? What is that called commonly? Waiter's tip. Okay. Now, it's important that you guys remember waiter's tip because it's a common thing that happens with babies, especially babies that have very hard time with delivery. So the physician goes in, tries to do a delivery using a kind of a basically traction, and pulls the baby. And in that process, it messes up the upper trunk divisions of the brachial plexus. So what is likely the area, right? What spinal levels are going to be messed up with Herb Duchesne? Exactly. C5, C6, and sometimes C7. Okay. Keep C7 in the minor kind of category. It's a common thing. Herb's policy, you got to know this. It's a common presentation with babies. Okay. Um, so we'll cover herbs, and now let's do this one. This way I get a baseline of your guys' knowledge. make sure you guys read the questions carefully because you might know what is happening in terms of what's going wrong, but they're going to also ask you what is the normal thing you would like to see or likely see. So they can ask the question both ways. Awesome. Exactly. You guys killing it. Inability to laterally rotate the arm. So the baby, if you guys think back to herbs, right, Duchenne policy, the baby was essentially adducted and it had like a medial rotation, right? So if the baby's has an inability to laterally rotate, that's what is likely damaged here. Okay, so we're going to go through that step by step. So what nerves are likely damaged? It's the suprascapular nerve, axillary nerve, and the musculocutaneous. And they can ask you guys this in multiple different ways. The suprascapular nerve is a branch off of what structure, guys? Exactly, the superior trunk, okay? If you remember that, it's a branch off of the superior trunk, okay? Critical to remember. Axillary is one of your branching points. The musculocutaneous is also a branching point. So if you combine the two, you can see how you can get a spinal level kind of organization that's likely damaged. So C8, C5, C6, and sometimes C7, okay? If C7 is messed up, what is likely also going to be the issue? What other nerve could be messed up? Not a branch. We're talking about something that comes off of earlier in the roots. Long thoracic, absolutely. So you guys see how I'm taking this brachial plexus and making it into a narrative, okay? That's what you guys need to do with the brachial plexus. Don't draw it out. I keep on saying this. Don't keep just drawing it out. It won't make sense to you until you put it into an applicable clinical presentation, okay? Herb's Duchenne versus Klumsky's policy. We're going to go through it step by step, okay? Now, upper brachial plexus level damage, also known as Herb's policy, it's C5, C6, commonly seen with babies because of how they're delivered, especially the physician or the OB-GYN that's kind of delivering the baby might essentially twist the baby's head just a slightly, and that causes the upper portion. If you kind of stretch it out like this, it can cause upper level brachial plexus damage, C5 to C6 level. Okay, you're gonna have sensory loss along the lateral border of the limbs, right? That's the dermatomal levels. You guys can identify C5, 6, and plus or minus C7, depending on how it goes. It's gonna mess up the SAM, okay? SAM is suprascapular, axillary, and musculocutaneous. So upper brachial plexus, think of SAM, okay? That'll help you kind of root out which muscles are likely gonna be damaged. Here, the baby has limited movements of the shoulder. Physical examination, his shoulder was internally rotated and his elbows extended. This is a classic kind of presentation of herbs, okay? We're gonna go over Duchenne in a hot minute, okay? Duchenne is the lower aspect of it. Now, a common thing is if they're also delivering a baby and they use the arms to kind of essentially pull the baby out during delivery, or if someone falls and hangs on to a tree or limb for too long, it can have damage to the lower brachial plexus. So C8 and T1. So what levels are likely going to be messed up dermatomally? Obviously C8 and T1. We can kind of get that out of the way, which is going to be your pinky and your ring finger are likely going to be having issues, as well as T1, which is closer to the inner aspect of your arm, okay? We're gonna go through those. Loss of flexor carpi ulnaris and the medial 1/2 of your flexor digitorum profundus, okay? We're gonna go through all of those the intrinsic hand muscles. This is a nice picture from USMLE first aid. So if you guys use that, it's really helpful because it outlines every single thing that is likely messed up, okay? Herbs, deltoid, your infraspinatus and supraspinatus, as well as your bicep brachii are all present with your waiter's tip. So you guys see how this kind of whole tabling helps a lot with telling you how each of these are going to present. Klumsky's policy, you're going to also have Klumsky's claw, which is the clawing that you have here. Keep that in mind. It's going to help you a lot. Now, the thoracic outlet syndrome is a common thing that leads to Klumsky's policy. Okay, it's where a child or an individual is born with an extra cervical rib, right? Obviously, you're going to have the first rib starting at the T1 level, but if you have an extra one at the C7 level, it can mess up the lower roots of this brachial plexus. So C8, T1 can be messed up often. And your guys' favorite, wings to heaven, okay, which is the long thoracic, right? Also serratus anterior muscle, right? If you keep that in mind, you know how it's going to present. C5, C6, C7, wings to heaven is how I remember what are the different cervical regions that need to be messed up to present with wing scapular. Okay. Awesome. Okay. Let's go over the roots. There are three kind of major divisions that you guys have to keep in mind. Dorsal aspect is going to give innervation to rhomboids and the levator scapula. Okay, C5, what's the mnemonic to keep the diaphragm alive? Shout it out.
C4-5 alive. 4C5.
Yep, 3, 4, 5 keeps the diaphragm alive, okay? Critical to remember that. And one of the contributing aspects is, of course, C5, the division of the phrenic going downwards and giving innervation to the diaphragm, okay? Long thoracic, your guys' favorite, C5, C6, C7, wings to heaven, long serratus anterior, okay? Once again, this can likely be messed up when you're, the classic stem that you're going to see is, the patient is unable to comb their hair. What is the likely nerve? It's going to be long thoracic, less often going to be the trapezius, but they prefer to ask for the serratus anterior long thoracic salt. Okay, let's go over the trunks. Trunks has only two major ones that you need to know of for now, which is the super scapular, right? That goes to the sits, SI components of the sits, supraspinatus and infraspinatus, okay? And then the nerve to subclavius. This is less often tested, but keep that in mind. It's something that they can ask. They prefer to ask about the sits muscles more often with the trunk division. Okay, now we get to the chords, okay? Chords are tough because there's a lot of different branching points and you're like, this is overwhelming, but what you need to know is, of course, the lateral pectoralis, right? That's going to the pectoralis major, the medial pectoralis that goes to the major and the minor. Those are the critical ones, and they spend less time. I think they might ask you guys a question about the thoracodorsal because that goes to the latissimus dorsi as a second order question, but they spend less time going over the subscapularis, and as well as the subcapularis and the teres major. They prefer these three in terms of asking questions about the brachial plexus based off of this. Okay, I don't really like Marmu. I'm going to be honest with you. I have a hard time remembering it, but I'm going to show you guys a better trick for remembering the terminal branches, which is this. Okay, I don't know if they included this in your guys' lecture, but they even didn't include it in ours, but they did include it in upper term folks lectures, and I thought it was super helpful. So this is how you can kind of remember your brachial plexus branching points, right? The lower kind of segments. It's basically using your fingers, okay? C5 is your thumb, C6, C7, C8, and T1, okay? If you have that, kind of know that those are the divisions of your brachial plexus, you can start doing the entire motion of this kind of hand gesture, okay? First is the Three Musketeers. So the Three Musketeers is talking about the musculocutaneous. It's C5, C6, and C7. Assassination is going to be C5 and C6, which is the axillary, okay? So C5, C6, okay? Rats are going to be radial, so that covers the entirety. So it covers C5, C6, C7, C8, and T1. And then, of course, mice is talking about the medial, so C5, C6, C7, C8, T1. And then the unicorn of the entire family is the two unicorns, so C8 and T1. Okay, if you guys do this hand gesture, trust me, it's going to put it into practice and memory of the brachial plexus rather than having you guys spend time drawing it out a bajillion different ways. Now, fractures, they love this. They love this. Okay, I will repeat that. They will ask you guys a question about this. So whenever you have a fracture or dislocation of the humerus, right? Remember, it's anterior, inferior for the dislocation. For the fractures, it's going to be a supracondylar fracture, okay? And it's likely going to damage the axillary nerve as well as the posterior circumflex humeral artery, okay? Those two are the two things exiting out of your quadrangular space. You guys see how everything's coming into a picture now, right? In terms of dislocation, in terms of fractures, etc., because it's all becoming a picture. Now, mid-shaft fracture is going to be commonly seen with the radial nerve as well as the deep brachial artery. So they can quickly ask you guys, it's a straight up a common thing, mid-shaft fracture, what artery is damaged? And they can be like, and they'll give you a slew of options and you can quickly identify it's radial nerve and the deep brachial artery. Very simple, very straight. I'll give you guys a mnemonic at the tail end of this, okay? Oh yeah, we're gonna do it one question before we get to the entirety. I know I got so many messages from you guys about like, how do I study the brachial plexus? I am traumatized. If you guys do this a gajillion times in terms of putting it into practice, it's going to help a lot rather than drawing it out. Okay, what did you guys think? So the patient is unable to extend his left wrist, fingers, thumbs, although he is able to extend the elbows. Because remember, this is likely a mid-humerus, mid-shaft fracture. So the answer is going to be radial, but remember the radial nerve and the innervation to the flexion of the elbow, or sorry, the extension of the elbow is already given off early on. So that is preserved, whereas everything lower is essentially done. So the key thing is, first thing that goes is as you go proximal to distal, more structures are lost as you go that's more proximal to your body, right? Proximal to the core of your body. So they really like these exceptions, so keep that in mind. And the answer here is radial nerve mid-humerus, okay? Mid-shaft fracture, mid-humerus fracture, okay? Mid-shaft fracture, radial nerve. Remember, the branching to the tricep brachia exits before the radial nerve, before the mid-shaft kind of fracture. So the extension of the upper arms are still intact, but they basically lose everything below, right? Sensory and motor. Remember, the closer you are, the more things you lose in terms of damage-wise. Next thing we're going to cover is the supracondylar fracture, okay? Previously, when we looked at the surgical neck, right? A surgical neck level trauma is going to be axillary. Now here is the lower, more distal division of it. The median nerve gets messed up with the supracondylar fractures, okay? Critical to remember, medial nerve. Median nerve, not medial nerve, okay? When you get to the medial epicondyle fractures, that's going to be the ulnar. So everyone always asks me how exactly it looks. It basically lobs off a piece that's more medial. So you always have to think about the body in anatomical positions so that you can position yourself to which side is going to be damaged. So based off of this, is this a left or right humerus, guys? Left, okay? You have to look at the anatomical neck and you have to look at the placement of the bone in terms of the ulnar, right? The ulnar is going to be more medial to you. So when in anatomical position, obviously, if you're just, a regular human being walking around, you're going to be like, that's not medial. Like, I don't know what you're talking about. But here, always anatomical position for MSK. Cool. Here is the mnemonic that you guys have to remember, okay? Humerus fractures from proximal to distal, arm, is the mnemonic, right? Axillary first, because we're talking about a surgical neck fracture or potentially a humeral dislocation that's going to present with axillary nerve issues. Whereas radial is going to be mid shaft, and then supracondylar is going to be median. And of course, the full mnemonic is if you want to add the U here, you got to arm U, right? Think about like weapons, arm U, which is going to be epicondyle fracture is going to be more of the ulnar nerve. So that basically divides up how the presentation is going to be. So whether it's going to be present with the thenar eminence, with the ulnar one, or it's going to be present with the radial one. So you guys can kind of outline those based off of the first aid picture right here. Okay. Now, everyone freaked out when I showed this to everyone last term, but what you need to know is the vasculature, okay, based off of the fractures. You don't need to know the veins as much. They don't spend too much time on this because most often in terms of trauma level, you're going to see these, right? Surgical neck, it's going to be typically the posterior humeral circumflex is messed up, okay? Mid shaft, you can either have the profunda brachial artery, right? And then anything after that is going to be more regional. You can have any of your interossei muscles, interossei arteries messed up, depending on where it is in the forearm. You can have a radial artery. All of those you guys can pinpoint because the radial artery is the first thing that we use as a landmark, right? Whenever they say you take a pulse on someone, you're not going to, use the upper portion of their neck to take the pulse. It's better to take the pulse at the radial location. And from that, you guys can draw like derivatives of how the other arteries run. Okay, that's how I used to learn this. Okay, know these based off of clinical correlates and it'll make your life much simpler rather than having to memorize all of the exact divisions. Okay, obviously you guys do know the exact divisions now because we went over the branches of the aorta as well as the upper shoulder region of the branching points of these arteries. Let's do this question. This is a classic. You guys have probably saw a Gray's questions on this already. If you guys have been keeping up with your Gray questions. Okay, I'm going to give you guys less amount of time because we are almost running out because we have a lot of things to cover. And the answer is annular ligament. Now, what is the diagnosis, young doctors? What is this called?
Nursemaid's elbow.
Nursemaid's elbow, okay? It's a common thing. It doesn't happen in adults because the ligament, the annular ligament, definitely tends to maintain its structure much better. And the structures that basically go and attach, right? We're talking about the the radial bone, right? It attaches to this region and it's completely fine, right? As an adult, but it's more malleable in children and you can essentially pop it back in place, right? And obviously when you still pop it back in place, there's a greater likelihood of it coming back over and over again, but it tends to be a more benign thing. It's not going to lead to any sort of major thing. The pain will go away almost instantaneously because you just have to pop it back in place and all of the innervation and structures and muscles basically go back to their appropriate region. So it's going to be affecting the radius, right? So annular ligament, very much a buzzword for the nursemaid's elbow. Okay. Now, articulating surfaces. So the radius articulates with the capitulum, right? This is a straight up memorization thing. It articulates with the capitulum right here. And the trochlear division basically articulates with the ulnar, okay? So radius, capitulum, ulna, trochlear, okay? Once you know that, you're basically set in terms of articulating surfaces. Of course, on the posterior side, you can kind of see the olecranon process. Not the biggest high yield thing, but it is useful to remember the olecranon process because it tells you regionally like and what bone you're likely looking at. Okay, cool. Now, memorization, I hate to tell you guys have to memorize this, but there are divisions of the median nerve. Obviously, they have to, because as you guys get closer to the fingertips, you're going to have more kind of branching points because they go and branch off and innervate different muscles, both for sensory as well as motor input. The median nerve gives way to the anterior interosseous nerve, right? Interossei is talking about in between, in the forearm, in between, there's a space, right? Between the radius and the ulna. And one of the branching points of the median nerve is the anterior interosseous. So it basically branches off and goes through this kind of anatomical kind of space. And that's why it's called the anterior interosseous nerve, even though it's a branch of the median nerve. The radial nerve gives way to the posterior interossei. So you guys can see how you can have different clinical presentations based off of this, and they can ask you which nerve is overall messed up. Ulnar artery has two branches, okay? You guys see how it changes, right? The ulnar artery gives way to both the anterior interossei as well as the posterior interossei artery, okay? Critical, these are the arteries, goes with the ulnar, the median nerve goes with the anterior interossei nerve, and the radial nerve goes with the posterior interossei nerve. Okay, let's do this question. These are tough, guys, but we will get through it. Exactly. Nursemaid's. Now, if you guys have a hard time remembering your flexors and all of your kind of digits and the muscles that are going to them, I highly suggest you guys watch Dr. Preddy's. And I gave you guys a link to his channel, or at least some of his videos that kind of show which one, which muscle goes to which point and what its function is. Okay, you guys are absolutely correct. It's the flexor digitorum profundus, right? Now, when they're talking about profundus, you're talking about the distal most point of your digits. Okay, this is critical because the divisions tend to blur when you're talking about one nerve versus the other. So we're going to talk about it and go through it. Now, your flexor digitorum profundus, FDP for short, one half of it, right? The medial division gives one half of it, right? So the ulnar division gives way to digits 4 and 5, right? So your pinky and your ring finger basically gets the innervation from the ulnar, whereas the lateral, your thumb, as well as some of your other pointer, indexing, and your middle finger both get innervation from the median nerve, okay? So this is why it's important. This is a very unique thing, so they like to ask it. So they're like, oh, patient comes in, he or she is unable to basically flex their flexor digitorum profundus of their fourth and fifth joint or fingers or phalanges, and what nerve is messed up. And you quickly have to identify it's the ulnar division as compared to the median division, because we're talking about something more medially located as compared to laterally located. Okay. So let's go over this again. Flexor digitorum profundus attaches to the distal phalanges, right? I like to think like profound people tend to be far off in society. They're in their own kind of little location because they like to think they're in their ivory towers. So they're distal, right? They're farther away into their phalanges. Now, median nerve, right, in blue, whereas the ulnar is in the lateral, or sorry, the medial more divisions, whereas the median is more lateral. Okay, that's the kind of the tricky part. These are your digitorum profundus, two important divisions. Whereas the superficialis, right, superficial people are more proximal. They like to think they're like close with everyone, even though they're not. What happens is the median nerve goes and gives innervation to the flexor digitorum superficialis. So as you guys can see, this superficial kind of damage and any sort of median nerve damage tend to affect more of the proximal phalanges as compared to the distal phalanges, because think about it, you're knocking out a lot more with the median nerve because you're knocking out these, right? One half of your flexor digitorum profundus, as well as a giant chunk of the flexor digitorum superficialis. Okay, all done by the median nerve. Now, okay, everyone loves these. I promise you guys are going to have a grand old time with this. The dirtier the mnemonic, easier it sticks in folks' head. But the carpal bones are scaphoid, lunate, tracheum, pisiform, trapezium, trapezoid, capitate, and hamate. Obviously, there are ones that are more important than the others, so I'm going to outline some of those via questions. So the mnemonic that you guys have to remember is some lovers try position that they can't handle, okay? The way you can identify in a radiograph image of this, they likely not going to ask you based off of radiograph image because it's so hard and they'd have to isolate it like this. But you can first identify the thumb if it's given to you, right? And the next, you have to identify the radius. Now, when we were looking at the initial more proximal division between the elbow and the humerus, right? The humerus and the radius and the ulna, you guys saw that the ulna was the bigger portion, whereas at the wrist, the radius tends to become bigger and the ulna tends to get smaller. So based off of that, you guys can find out which is more proximal and which is more distal. So scaphoid is right here, right? Scaphoid, you guys got to know very well, okay? Next thing you guys need to know is the hamate and the lunate, okay? These three are the critical ones you guys got to keep in mind. And we're going to go through all of them based off of questions. I'm going to give you guys 30 seconds each because these are locked. Okay, so most common fracture, this is very buzzwordy, most common fracture tends to be the scaphoid, okay? Absolutely, you guys crushed it. So keep that in mind and you'll get it down to a T, okay? Most commonly fractured, scaphoid. Let's do scaphoid right here. It looks like a kind of a peanut. You guys see this? Like you guys see the fracture right here. So that is how you can imagine the kind of presentation. They often don't give you the image because once again, I said it's so hard to identify, but it tends to damage the radial artery because remember the anatomical snuff box is close to this region and it actually makes the floor of it. So if you guys can remember that, you can kind of use that to your advantage of remembering portions of the anatomical snuff box. It can cause avascular necrosis. So avascular necrosis is going to present in where? Is it going to be in your pinky or is it going to be in your thumb area? Where is the scaphoid is the question. Thumb area, exactly. So if you guys can remember that, makes your life so much easier. Radial artery, it's closer to the thumb. So the thumb is like in this region. They just have like kind of cropped it out so you guys can't see. But avascular necrosis, very bad because the radial artery gives blood supply to a huge chunk of the muscles and structures here. Let's do this question. Okay, let's see. And the answer is lunate, exactly. So this is the most commonly dislocated one. Whenever they say like a person falls out with outstretched hands, lunate. Start thinking about lunate. If it's fractured, then think scaphoid. Scaphoid is going to mess up two things. It's either going to compress the radial nerve and the artery, whereas the lunate, the most commonly dislocated, is likely going to compress the median nerve. Okay, that's the dislocation. Let's all kind of tie it together with the final kind of one. Okay, posterior dislocation, we'll kind of get into this, okay? Now, before we go on and show you guys the last component of it, is knowing the anatomical snuff box. A lot of folks in our term really didn't spend too much time remembering the divisions, right? Like the bordering of this. And they ended up losing 1 or 2 points here and there. I just want you guys to get this right. The lateral, right, medial, roof, and floor are all equally likely tested, but they definitely prefer the floor because of the trapezium, the scaphoid kind of fractures, okay? They're going to ask you about the scaphoid more often than not, so keep that in mind. But I threw this in here for completion's sake so that you guys are well prepped for questions about kind of small regions like this, okay? Now, before we go on to that, I do want to ask you guys, what is the one that I told you guys that you need to remember is the hamate or the pisiform, okay? Both of those, whenever they get fractured, right? There's a structure on the hamate that's called the hook of hamate, okay? What happens is the ulnar nerve runs through this region, right? If the hook of hamate gets fractured, it basically can go and shear or cut off the ulnar nerve. And that basically shuts down the ulnar nerve very proximal to a lot of the musculature there. So you're going to have a lot of issue in your kind of your hypothenar kind of eminence area. So we'll cover those. They also like to ask you guys questions about carpal tunnel. So keep that in mind. Any sort of median nerve issue that's more proximal in the wrist area is always going to present with median nerve because the ulnar nerve goes through the Guyon's canal, right? I hope I'm saying that name correctly, but Guyon's canal is going to contain the ulnar nerve, whereas the median nerve goes through kind of a thick bundling structure, and that bundling structure is the carpal tunnel kind of tunnel, and that tunnel holds a lot of different vasculature as well as this median nerve. So that's why the classical presentations of carpal tunnel can be seen. Now, what is the test that you would use to identify someone with carpal tunnel, guys? Penal test, that's one of them. What's the other one? There's 2 tests. Yes, Frohman's test, I believe, are the 2. So the Tino test and the Frohman's test, those are critical. If you guys can remember those are going to be important for your any sort of carpal tunnel. You're going to typically you're going to perform this on the patient, and they're going to have numbness or tingling based off of the positive signs of the test. Okay. Let's do this. These are the little fractures, and then we will get to the lower limbs. I can't believe we're covering all of it in like 3 hours. Okay, we were split. And I figured you guys are going to be split on this. So this is a classic presentation of our favorite Smith's fracture. Okay, now the Smith's versus the Coley's fracture. This is like not the biggest, highest yield, but I think you guys should get this point, and it's a nice, easy point that you guys can get on the exam. Now, the Coley's fracture, also known as the Dinner's fork deformity, is basically when the posterior it's a posterior fracture, meaning the distal fragment basically moves posterior. So it's really hard to imagine this unless you guys look at a radiograph image or like you have a diagram of this. So just keep that in mind. So if they say a posterior fracture with the distal fragment moving posteriorly, it's Coley's. Whereas if it's moving anterior, right, it's going to be the Smith's fracture. Okay, and that's going to be the garden spade one. So anterior Smith, like think of him or her kind of hitting the anvil and kind of shaping like a Smith, like a normal Smith. Whereas Coley sounds like a fancy person with a dinner fork and all sorts of jazz. Okay, posterior versus anterior. Yes, question.
So the way the question was asked, it says the radius is angled forward. Like,
Mhm.
what does that, I think I just don't understand what it means.
Yeah, that means it's displaced anteriorly. So it's the fracture of the
Oh.
distal radius. So just keep that in mind. You always have to put these based off of how they sound. So this fragment is moved forward. So when it says moved forward, it's moved anteriorly. They can ask you guys both in layman's term versus like the clinical term of anterior versus posterior. So just keep that in mind too. Okay.
Okay, thanks.
Yeah, no problem. Let's
If they had
do.
asked you a question about the Coleys, would have they like what did they say angled backwards? Like what did they say for that one?
Yeah, the fracture had they could say like the fracture is posteriorly located or angled backwards are all great examples that they could use for Coley's.
Okay, thank you.
Yep, no problem. Okay, let's do this one. We're supposed to assume anatomical form. Absolutely. That's why the forward is anterior. That's correct, Maria. This one's a tough one, guys, because it's an exception, not a rule. So I figured that this would be the case, and I know they definitely mentioned this during lecture, and I promise you guys, you just probably glazed over it because it's a concept that's very unique. The correct answer is going to be E, as in elefante. Okay, 33%, not bad, guys. It's the inability to adduct the thumbs because what's likely affected here is the median nerve, right? You got to remember it. The cut is down the surface of the flexor retinaculum, but not into it. So that means it's very superficial. It's more medially located, right? It's a flexor retinaculum. So you got to use your contextual and anatomical clues to know that it's not the median nerve that's affected here. It's the ulnar nerve. So based off of the ulnar nerve, you got to know that it's going to be going to this exception, which is the adductor pollice muscle. Okay, the adductor pollice muscle. Okay, if you guys look at my hand, and you guys try to adduct, right, follow through with it, you guys will see that the adductor muscle is actually, it's one of the exceptions, is done by the ulnar nerve. It's one of the kind of the branch that loops around and gives innervation to the adductor pollicis muscle. So adductor pollicis is on the lateral side, but it's innervated because there's a looping division of the ulnar nerve that comes around and gives it innervation. Okay, that's why when you guys do your DABS and PAD kind of assessment, you guys can also see that the adductor, right? Most of the DABS and PAD is done by the ulnar, right? The dorsal versus the DABS and PAD, the posterior, right? So when you guys have your dabs and pad, you guys can quickly remember that it's the ulnar, but also add on to it, which is the adductor pollicis muscle. Okay, adductor versus abductor. There it is. Thenar eminence versus the hypothenar. Thenar is median, okay? Hypothenar, ulnar, and always the dabs and pad. Dorsal versus the palmar adductor. Sorry, I said posterior, but it's palmar adductor. My bad. Let's go over the dabs and pad as well as the little bit of the loaf muscles. Okay, the median nerve gives rise to the thenar muscles. Okay, these thenar muscles specifically deals with opponent's pollicis, adductor pollicis brevis, and the flexor pollicis brevis. So if you guys think of your brevises, you can start thinking of your median nerve. That's the loaf muscles. Okay, and the lateral two lumbricals. Okay, lateral lumbricals because they're closer towards the thumb. Okay. And once again, anatomical positions, folks. Whereas your ulnar is all talking about your mini-me's, right? Except the unique one is the flexor digitorum mini brevis, right? It's the mini-me with the brevis, so keep that in mind. It's the one little exception. Don't get tripped up by the brevis here. Keep that in mind. And the medial two lumbricals as well as the intraossei muscles. Because we talked about the intraossei, remember your dabs and pad and all that jazz. Okay, that's the hypothenar So if you guys have these straight, this is pure memorization. You gotta know these because they can present it to you based off of fractures that are further up or closer to the wrist, and you gotta tell the difference between the two. Okay, the lumbricals. The lumbricals are very unique because what happens with the lumbricals is that they have a unique presentation because they are flexors, except there's a unique point where they do an extension. Okay, at the proximal division, right, and more proximal, like the metacarpal region, they're going to be your flexors because they're flexing. Think about trying to make a P, like the lumbricals form an L shape, and if you guys think of the L shape that forms here, the more proximal metacarpal region, right, they are going to be flexing. But there's a hood-like structure that goes up from these proximal divisions to the distal divisions where they do the opposite. So that opposite kind of musculature and the ligaments that run through it allows for these points to be extended, right? That's how you're able to do this kind of hand movement, right? It's important that you guys know this division, okay? Ulnar nerve gives medial two lumbricals, whereas the median nerve gives the lateral two lumbricals, just like the other divisions, but they're both flexors at this point, at the proximal division, whereas in the exception to this is that at the interphalangeal joints, right, closer to your fingertips, they are going to extend both your proximal and your DIP, right? Proximal and distal. There you go. Dabs and pad coming back to bite you guys once again. Dorsal interossei abduction, whereas pads palmar interossei adductor. What nerve does this? Ulnar. Okay, so you guys have to start clubbing your ulnar nerves, what they do versus the median nerves, how they're going to present based off of injuries. Adduction, abduction. Okay. Let's do a question. This is very buzzwordy. They're not often going to say benediction, but they will ask you guys, you know, the lateral 2 to 3 fingers are messed up. What is likely the nerve injured? And you have to be able to quickly identify what nerve it is. Okay, what's the answer? Exactly, median nerve. You guys gotta keep these rock solid. Okay, absolutely. Now, these hand lesions, right, they're happening based off a location of the lesion, okay? Distal ulnar, proximal median nerve, distal median nerve, and then proximal ulnar. So you gotta make sure the patient does all of these movements, right? Making a fist, opening their hand, making a fist, so that you can assess whether it's the ulnar nerve or if it's the median nerve that's messed up, or if it's a radial nerve. Any sort of divisions have to be kind of identified. But for this question, what we were looking for is asking the patient to make a fist. The patient is unable to do that is because the proximal median nerve is unable to contribute and give musculature motor innervation to these divisions. So only your medial two fingers are able to close. So that's why it looks like the Pope's blessing, right? That's the hand of benediction, or Benedict's attitude, or however they say it. Ulnar clawing is the opposite of that. Whereas you're going to ask the patient to extend their fingers, right? But it's at the distal ulnar nerve. And they're basically, you're going to ask them to extend their fingers, but only thing that really works is the two or three fingers that are more laterally located, and your proximal or more medial two fingers is unable to extend. Okay, that's the ulnar nerves function being messed up. Okay. Cool. That being said, I'll give you guys another 2 to 3 minute break, and then we'll pick right back up. So let me get this party started. Okay. Guys, the thoracic component of MSK isn't actually that high yield, as well as the abdominal portion. The reason why is because you have two separate modules just purely dedicated to it. What I'm going to go over is the essentials that you guys need to know for the exam, and feel free to take notes of what you need to know, jot down any information, but they're going to cover a lot more of it in CPR and as well as DM, which is term 2. So let's get the fun jazz out of the way. So thoracic, you guys need to know vans, okay? When I say vans, first thing that should pop up into your mind isn't the shoe company. What should pop up in your head is veins, arteries, and nerves, right? We're talking about the neurovascular bundle of the thoracic wall, okay? Obviously, they can spend some time going over like the muscles and how like they go from like from one side to the other and how like they cross over and all those things. You don't need to know that as much as doing pleural taps and you know, your thoracocentesis and thoracostomies. That's what they like to test because it's a very unique thing, because you're trying to avoid these structures. Okay, obviously you have your lungs here, and you want to puncture to a sufficient degree so you can drain fluid out of them, but you don't want to mess up your neurovascular structures that are running through the ribs. Okay, they're just below the ribs, so always the critical thing to remember with this is that when you're doing any sort of thorax levels components, you got to avoid your vans, right? Which is the anterior intercostal vein, anterior intercostal artery, and the intercostal nerves, right? These are the critical. They can ask this in several different ways. What is the first structure that you're going to likely damage if you're inserting a needle here? What's the first structure you're likely going to hit? Is it going to be V? Is it going to be A? Or is it going to be an N? Which one is closest if you're inserting a needle right here? Feel free to shout it out.
Nerve.
Nerve, okay? Nerve is the first thing you're likely going to hit, and that's bad because remember that basically provides the innervation to these muscles here, and that's involved in breathing too, because the ribs expand, and that expansion is facilitated by these intercostal nerves. Critical to remember. Just for definitional sake, thoracocentesis is a pleural tap to sample the fluid from the pleural space. Obviously, you guys haven't covered microbiome or anything of that jazz, so any sort of fluids is just going to be fluids to you guys. But if there's any sort of microbiota infection or anything that's gotten really into the pleural space, you want to test what type of bacteria or anything that's residing in this area. The thoracostomy is essentially you're going to put a chest tube in place so that you can either drain fluid or air from this area. You're going to have a lot of different presentations of it. You're going to learn more about it in year 2 of medicine. Okay. Thoracocentesis, this one is critical. You guys got to memorize this numbers. Okay. So you have to insert the needle so that you avoid the vans. Like I said before, you have to go mid-axillary line during expiration, and that's how you're going to basically insert the needle. And the key thing to remember is superior to the inferior rib, okay? Superior to the inferior rib, and they're gonna ask you based off of several different regions. So let's do this question. I said 30 seconds, 30 seconds it is. Okay, a bit of a division here. I know you guys were tempted by 9, but the answer here is 11. Now, why is this the case? So decreased fermentis present in the right lower lobe. Chest X-ray shows pleural effusion over the lower thirds of the thorax on the right paravertebral line. This is critical, okay? The paravertebral line versus mid-clavicular versus posterior. We're going to cover all of those, but the answer here is 11th because of the paravertebral line. Okay, we'll cover this. Okay, so divisions. Okay, you have to know these 3 very, very well. Now, how they likely are going to ask you guys this question is that one, the fluid is going to collect in the costodiaphragmatic recess, which is basically right here. And this is the area that we likely use to sample for any sort of kind of changes. Obviously, at different points, you're going to have more space to work with, so you can insert at any different point. But here in the mid-clavicular line, it's going to be between ribs 6 to 8. So what's likely the number that you're going to insert into? It's going to be like rib space 7. Okay, that's likely the number that they're going to give, or they're going to give you a range like rib 6 to 8. Okay, if you remember those two kind of divisions, you're going to be fine. Mid-axillary, right, is just like what we're talking about. It's the in-between space, right? We're talking about where your axillary or armpit region is, and then as you go downwards, you're going to find the mid-axillary line. That's between ribs 8 to 10. So what's the number that's going to be in between what space? It's going to be rib space 9. Okay, and then of course your paravertebral is the posterior aspect of it, and that's going to be between 10 and 12. Okay, so that's the critical location. You guys got to know all of these, and it's going to help you pick up points here and there for your pleural taps, as well as collecting fluids from this region. Okay, diaphragmatic recess is the ideal point for the thoracocentesis. Okay. This one was like we essentially got 1 or 2 questions on it. Nothing too crazy, but still a good one to know. Awesome. Okay, you guys were definitely split on this. It's probably because I'm rushing through all this. The answer here is D. At the descent of the diaphragm with the protrusion of the abdominal wall, thereby increasing the vertical dimension of the thoracic cavity. So there's a nice picture on Amboss that I use to kind of like understand this. Now, whenever you guys are using your kind of axillary divisions, right? Your ancillary division, sorry, not axillary. You're going to either be using the pump handle movement or your bucket handle movement, okay? Those are critical to remember as well, but the normal kind of increasing the interthoracic space is done by this. The diaphragm essentially contracts and falls down, right? So that you can expand your basically empty space. And remember, a nice throwback to your physics days. Whenever you have an empty space, it's going air or any sort of gas is trying to fill up that space. Like it doesn't like a negative pressure, right? So it's going to then fill in, and naturally air is going to flow inwards. And as you expire, the diaphragm relaxes and comes back to its resting position, and then the normal process of expiration comes out. Okay. So this one's important to remember. Pump handle, it increases the AP dimension. So, take a nice deep breath in. It helps you relax right now too. So you're using your sternocleidomastoid essentially to pull up the structure, as well as the bucket handle component, which is the lateral dimension of your entire thoracic cavity. Okay. Now the contraction of the diaphragm increases the vertical dimension. So that's why you can see like your whole thoracic cavity is basically expanding the process of inspiration. Okay, that respiratory cycle, you're going to learn a lot more, and this concept is going to come back in CPR as well. Okay, bucket handle, lateral. Think about it, you're holding a bucket on the side of your hand, right? Like on the side, you never hold it out in front. Like no one carries a bucket like this. It's always on one side. And the pump handle is like, think of like you trying to like, I don't know, pump water. I don't think anyone's ever used this structure in their life, but quick way to remember AP versus lateral dimension. Okay, let's do this one. This one's a very quick one. You guys can pick up a point here and there based off of this question. Exactly. This is very buzzwordy, guys. So the answer here is the anterior axillary pectoral node, right? Now, these are your sentinel nodes. Sentinel nodes, like I don't know, for some reason, it tends to be this first site of where you can have cancer spread, especially from breast tissue. So it's important to know the lymphatic drainage of the breast because this is how metastasis tends to happen. So the first one that they love to test is the anterior node, right? That's the first point. Then it jumps over to the axillary, like 75%, it goes to the axillary. Now, this is, I mean, 25% is still a big percent. You can have metastasis basically go from one breast to the other via the parasternal nodes because they cross communicate and it's a quick way for cancer to metastasize. So wherever the first node drains into of any of the quadrant, because you have to basically divide the breast tissue into 4 quadrants and you can find out where it goes. Okay. The buzzword for this is surgical exposure receives the lymph node from the tumor. The first receiving lymph node from this tumor, it's always going to be AP unless they ask something about metastasis to the next, to the other breast tissue. Okay, then it's going to be parasternal. Okay, that's a very buzzword one. The first node, it's always going to be anterior node. They don't really get into the other ones, so just keep that in mind.
Wait, real quick, is sentinel node just something that, where is it? Or is that kind of just a name for the first lymph node that anything kind of drains into?
It's the first lymph node that actually drains into. They typically call the anterior one because that's the one they like to biopsy right away for any sort of cancer. Once again, you guys aren't going to get into cancers until like term 4. So don't get too crazy caught up with this. So sentinel nodes, whenever you start thinking of sentinel nodes and they ask you the first quadrant where it drains into, you're going to start thinking of the anterior nodes for now. And if they tell you it metastasized to the other breast tissue, then go to the parasternal nodes. Okay. Cool. Let's do, this is just continuation. If you do like a radical mastectomy and it completely removes all of the breast tissue, the problem is they take out a lot of the lymphatic drainage from this area because they like to take a whole bunch and it can cause lymphedema. Like lymphedema sounds like exactly what it is. It's due to insufficient amount of lymph nodes and the proper lymphatic drainage, and it can cause edema. Edema is essentially when, and your lymph system, and you guys are going to cover more about this later, your lymphs are the first thing to kind of drain out your extra fluids that get pushed into the interstitial space when your blood kind of runs through this area, right? That's why your lymphatics are so important. But with mastectomies, you can mess up the essentially apical nodes as well as your lateral and the anterior pectoral nodes. And that causes likely like lymphedema, okay? It can also, this is the thing, when you're doing radical mastectomies, they take out a lot of structures and they can also mess up your serratus anterior and your long thoracic. So it's another common buzzwordy thing to kind of keep in mind, okay? So lymphedema leading to, lymphedema as a consequence of this mastectomy. Cool. Now, abdomen, you once again, it's a big thing you're going to cover in term 2, so I'm not going to spend crazy amount of time with it. So let's do this first question. Okay, let's see how we're doing. And the answer is, okay, yep, you guys are killing it. What is this landmark called? McBurney's point, right? McBurney's point is a common one that we use for appendicitis. It's an incision line that they use to kind of drain it out and take out the vestigial structure that is known as the appendix. But important to know is that the line that you need to draw is 2/3 of distance from the umbilicus, as well as the anterior superior iliac spine. So that's a very important landmark. There are other landmarks that are used for other things, but in terms of clinical relevance and thing that they're going to likely ask you guys about is the McBurney's point. Okay, that's how it looks. That's how you can draw the line, and it's a very quick and simple thing to get as a question and a point. Okay, this wasn't super crazy. We got like one question on this, but this is important because we're talking about the arcuate line. Now, why does the arcuate line exist is because above the arcuate line, we had certain structures running through it that basically that didn't allow for certain muscles and its ligaments to kind of create this bundle-like structure. Above the arcuate line, right, you're going to have your transverse kind of aponeurosis go underneath or below the rectus abdominal muscles. Okay, now that's above. Okay, we're talking about the above the arcuate line. Below the arcuate line, everything goes above the rectus abdominis muscles. So it's kind of a little flipped, but it's important to know this because structures that run here, right, at this point over here, like important to know is that there are certain vessels and vasculature that runs through here that's kind of a derivative of your from an embryo perspective. You guys don't get too much into that because when you cover endocrine and repro in term 2, you're going to get more of that knowledge. Okay, don't trip. You don't need to know too much other than the fact that this aponeurosis of the transverse abdominis goes below the rectus abdominis for above the arcuate, and below the arcuate line, everything goes above the rectus abdominis. Okay, so I included this picture not to scare you guys, but to tell you the essential thing that you need to know is the penetrating point between all of the divisions of the diaphragm. Okay, what is the mnemonic that you guys use to tell at what level each of the structures, vasculature, runs through this area, as well as the esophagus? I think the mnemonic is called I ate 10 eggs at 12. Okay, if you guys can remember that, you can basically find out where the inferior vena cava, right? I ate, right? Where does that cross over versus your aorta, your descending aorta, and as well as your esophagus. Okay, that's a very important, critical one. It helps you guys get a better picture. I just put this in here so that you guys have a better picture of how the overall vasculature and blood supply kind of run, and the divisions that you're going to likely look at as you guys get more further on in your term. What you likely spend more time on is, of course, the piercing points of the diaphragm and what structures go through it, and the external and the internal iliac. Okay, those are critical. We're going to go through those when we get to the lower limb. Okay, as well as a couple of the anastomoses here. So let's go through this one. Okay, how are we doing? I ate 10 eggs at 12. Okay, now the answer here is, of course, ascending lumbar. Okay, now why is it ascending lumbar? Because what we're specifically talking about, I know a lot of you guys were tempted by the hemiazygous and the azygous, right? What you need to remember is that the veins most likely adding as a collateral channel to allow blood flow from the lower to the upper parts of the body is actually coming from the ascending lumbar, right? So these are the ones I've highlighted here. I threw this from lecture, but I thought this image was much clearer. You guys need to know these very well, and you guys are going to be solid, okay? You got to know the left renal because it comes back again and again. As well as the ascending lumbar veins, as well as the hemiazygous, azygous, and the accessory hemiazygous, because the accessory is coming from the left upper limbs, and the lower limbs, right, is coming from the hemiazygous, but more specifically, of course, the left ascending lumbar veins. Okay, that's only these are really, they become distended, and it kind of looks freaky when you have a complete IVC blockage. It looks scary. I think there was an image included in your guys' lecture, but your cable system, right, has another route of getting blood back into the superior vena cava. So that's how you can kind of run through this and see how it looks. You guys can Google that image. It's kind of cool. Okay. Let's do, I think this is moving towards into the pelvic region. Okay, what's the answer? Let's see how it is. And the answer is genitofemoral. And this is an important one. You guys got to know the afferent versus the efferent limb of the cremaster reflex. And I'm going to go through both of those with you guys in a hot second. You guys did fantastic. Genitofemoral is the correct answer. Okay, this is the efferent limb. So this is the one that's actually doing the motor component of the cremaster reflex. The afferent component we're going to go over. Okay, the genitofemoral, right? It has two branches, right? And remember, you got to know these levels, L1, L2, and it branches into the genital branch as well as the femoral branch, right? And it runs along the psoas. And the reason you guys got to know your psoas is because your appendix kind of runs in this region, right? And the psoas is the first thing that likely gets irritated. So just another kind of hint to kind of keep in mind, okay? Cremaster reflex, afferent is the ilioinguinal, right? And that's like the inner thigh component of it. So it like, and this is specifically to males, right? It's just a reflex arc that ascends the testes so that you don't get damage to it based off of like a slight sensory input for the afferent branch. And then efferent branch is actually raising the testicular division. Pelvic, we're getting into the pelvic now. Let's do it. You guys are going to cover ER in term 2, and you're going to learn so much more than you ever needed to know about the pelvis, but there are a couple of critical things we were tested on for MSK. Okay, so what do you guys think this is? Now, this is a quick point that we captured when we were kind of learning this. This has a nice mnemonic even in first aid. The answer is the transverse abdominal aponeurosis. Now, remember with this is that you're basically any sort of male and essentially female structures start at the lumbar region, and as it's going down, it's going to drag more structures with it. And that's why it's so hard to identify this, because, well, I mean, the answer is transversalis fascia, and we're going to go over it, okay? External spermatic fascia, right? Formed by the external abdominal oblique aponeurosis. The internal spermatic fascia is formed by the transversalis fascia, and the tunica vaginalis is going to be super critical. We're going to go over that in a bit. And then the cremaster muscles you guys learned for your afferent and efferent limb, and then dartos muscles, you're going to learn more about it. So the answer is D, not D, it's sorry, the answer is D, but not C. So critical to remember. The mnemonic that you guys need to know is ICE tie. Okay, ICE is standing for the structures of the actual testes, whereas the divisions of the abdomen is what you're going to kind of penetrate through in order to create this. Okay, internal spermatic fascia is a division of the transversalis fascia. The cremaster muscles are a division of the internal oblique, and the external spermatic fascia is a division of the external oblique. So ICE tie. Okay, now, important thing with the tunica vaginalis, I don't know if you guys have covered this, but what type of issue would you see if the tunica vaginalis is open and filled with fluid? What's the diagnosis? don't know, did you guys cover this? I might be tripping, but the answer is hydrocephalus. Okay. And we're gonna cover it. Sorry, hydrocele, not hydrocephalus. So hydrocele is basically when you can do the transillumination test and basically shine a light under the testes and it will glow because of the fact that there's just fluid filling this space versus an hernia, which you guys, I know for sure covered the hernias. Okay. Awesome, you guys did cover it. So you guys need to know your hydroceles versus your direct versus indirect inguinal hernias. Okay, so let's do this question. My apologies. We just finished covering neuro, so I still have a lot of neuro terms floating around in my head. So I call it a hydrocephalus, which is talking about the brain. But hydrocele is specifically in this region. Yeah, I'll go over what we were testing on BPM 1 and 2 or FTM 1 and 2 at the tail end that you guys can focus on. Okay, I'm gonna give you guys a nice way to remember this, and I'm gonna save your guys' lives so many times with this. Okay. Indirect inguinal hernia is what we're looking at here because what you have to remember is that it passes to the deep inguinal ring. Okay, that's direct. It's specifically done by the indirect inguinal hernias. Okay, now the little mnemonic that you guys have to remember is MDs don't lie. Okay, MDs don't lie. So MD stands for medial direct, right? So it's medial to the inferior epigastric vessels, and it only passes to the superficial ring. So that's why MDs don't lie. So don't lie, which is LI, not like LYE, lie. So lateral is indirect. So that goes lateral to the inferior epigastric. And this is a very unique thing because it passes both the deep and the superficial ring, okay? And if it's a congenital issue, it can be a patent process vaginalis. And if it's patent, right, your inferior epigastric vessels can just basically pass right through and herniate into this region. Now, obviously, that being said, if it's patent versus filled with fluid, you got to run your differentials, right? Inguinal hernias versus hydroceles, right? If it's just fluid, hydrocele, and you can shine a light through it, you're like, oh crap, it's fluid. So it's lighting up like a bulb. So it's a hydrocele. Okay, versus a hernia. Okay, commonly with direct, you guys can kind of go based off of this, but don't use it as the rule. Direct tend to be self-administered, so you typically like lift a really heavy object and can cause this thing, whereas indirect tends to be more congenital and little kids have it. But that being said, that's not necessarily like a catch-all. So like got to make sure you read carefully and that they give you right contextual clues within the question stem to answer this. Okay.
Sorry, can you say that mnemonic one more time? I didn't catch it.
Yeah, no worries. It's MDs don't lie. So that tells you medial direct, lateral indirect.
Oh, okay. I just spelled the lie wrong. That's why I wasn't getting it. Thank you.
You're good. You're good. I had the same thing. I was like, LIE. Why are they? What's going on? Let's do this question. Okay. Now this is very unique and it's hard to kind of wrap your head around because I know you guys would be tempted by interspinous diameter. I had a gut feeling, but the correct answer is actually true conjugate. Okay, true conjugate doesn't change, right? It remains unaffected. I know you guys were like, oh yeah, relaxin, I'm gonna get the heck out of this. I'm gonna get the right answer. Now, remember for this, the interspinous is the one that needs to change, right? It's the narrowest. The baby has to pass through this, okay? But the true conjugate never changes, essentially, because the structures that are here, you would, they just can't move out of the way, right? Remember, the bladder is close to here. That structure and everything that's in here wouldn't change in terms of size, okay? True conjugate doesn't change in size. Interspinous has to change, okay? Be very confident about this. So you're gonna be solid once you know it. So another thing, they might ask you this, they might not. How you can identify the female pelvis versus the male pelvis. Like, let's just say someone like just put on a table in front of you a pelvic, like, and then they say like, is this a male or a female? Quickest way to identify the angle right here between the ischial processes is going to be oblique in the female, whereas the male, it's going to be more narrow, right, or acute. So that way you can kind of quickly identify the pelvis. I don't know how they can ask you a question stem about it. And obviously like the pelvic inlet is going to be much bigger in the female. So you can just use your different contextual clues to identify. Okay. This might be more helpful for your guys' lab exam. So just be aware of that. Okay, let's do muscles. I asked you guys a question about this today. Let's see if you guys remember. I asked questions in the Here's the TPLG kind of group, Facebook group. Feel free to join it. I have the QR link at the tail end. Shameless plug right there. I love it. Okay. The answer is pubococcygeus. You guys landed it perfectly. Amazing. This is a very common thing. You guys need to know pubococcygeus, any sort of incontinence, it's going to mess up the overall group of the levator ani muscles. Let's kind of look at it. So the common thing, they can either ask you either the puborectalis or the pubococcygeus, okay? Those two are the one that they likely ask you because they form the sling-like structure and they essentially help in maintaining continence, right? Incontinence is when you just don't have any proper kind of control of your excretory functions. They very less often, they ask you about the ileococcygeus because this is the one that's more directly involved in kind of maintaining everything inside. Now, the structure that you need to remember when you're doing like episiotomy that you're going to likely cut through is, of course, the superficial transverse perineal muscle, right? As well as, oh, that's the primary one, right? You're basically forming a episiotomy, which is the cut in the vaginal canal to the side of it in order to deliver the baby because the perineal body is right here. That was the question of the day that I asked you guys. You want to avoid this because if there's any sort of tearing at the perineal body, all of these muscles insert and attach to at this point, okay? And if that's, it's really hard to repair afterwards. So that's why they try to avoid it and do a little bit more damage in the process in order to avoid that so that the mother could recover quickly because these muscles can recover, whereas the perineal is a harder one. Yeah, fecal incontinence, because remember for this, it's both the pubococcygeus and the puborectalis for fecal incontinence. It's important, both of them are involved because these are a group of muscles that work in tandem, right? That's why when you have a relaxation of both things during, I mean, one of them can be relaxed and the other one can be definitely still tightened, but important to remember any sort of fecal incontinence as well as urinary incontinence can be either one of these, okay? Urinary is typically going to be, it's really hard. I mean, they typically don't ask you guys the urinary incontinence because they save that for the next module in term 2. So don't worry about the urinary one. Just know whenever they ask you any sort of incontinence, go with either one of these, typically pubococcygeus muscle. Okay. Cool beans, let's do this one. Killing it, guys. E, absolutely. So this is a positive Trendelenburg, like hip drop at the left side. So what's happening here? So the hip is dropped on the left-hand side. You're going to basically ask the patient to stand up and, basically stand on one foot. And if the superior gluteal nerve is injured, right, because it goes and innervates the gluteus medius and the minimus, okay? I think the common thing is everyone kind of forgets the medius and the minimus, and everyone focuses on the gluteus maximus because it's a big old muscle. But essentially, gluteus maximus is only involved in you standing up from a chair or from a seated position. That's why like you do squats and other things to kind of increase your gluteus maximus. The gluteus medius and minimus are critical for actually walking, running, moving. So you got to keep those things strong. Okay. That's also why we can give shots here as compared to like the gluteus maximus directly. You don't want to give them a shot here because you might potentially pierce the sciatic one. But I'm going off on a tangent. Important for the Trendelenburg sign is the opposite side is damaged, right? If the hip drop is on the left-hand side, the actual muscles that are damaged is on the right. And that's what we saw here, right? The gluteus medius and the minimus on the right-hand side is affected, okay? I gave you guys a nice diagram here so you guys can see actually how the innervation kind of branches out. And you can see also the sciatic and the obturator and all of those things. So waddling gait, there's like a whole picture and all that jazz, but you guys don't need to identify someone real person. So that's always a nice thing. Lower limbs, let's get through these. I didn't want to give you guys too much of the lower limbs because you guys just covered it and you're going to keep covering it next week. So I don't want to cover things that you guys haven't covered and give you guys a heart attack. Actually, heart attacks are your next module, so it'll be perfect. You guys would be like a module ahead. Cool. Okay. You guys, I know I knew why some of you guys picked B, but the answer here, I know this is a tough one. The answer here is actually E, guys. So 19%, you guys got it. Ascending branch of the medial circumflex humeral. Now, this is the point where you guys got to start taking age into account. B would have been correct if it was a kid, right? Which of the following arteries is most likely injured, resulting in the avascular necrosis, right? If it was a kid and they're having like anastomosis blood route, it's the acetabular branch of the obturator, right? Obturator in little kids, right? I think like less than age 10, there's a blood vessel that runs through the ligamentum teres and basically gives blood supply to the lower limbs. So that can kind of compensate if a kid has any sort of humeral head fracture, right? Femoral head fracture, sorry, not humeral, femoral head fracture, right? If you mess up any sort of ascending, like in the capsular area, it can cause ascending branch of the medial circumflex to like basically be shut down, and there's no more anastomosis route. So we're gonna go through those in a hot minute. So you guys need to know that this is the acetabular fossa. They're going to likely ask you guys that, as well as the articulating point of the femoral head and the femoral neck to the hips. So you guys need to know that the Shenton's line is super critical because they basically use this to identify, if you have like a wider gait based off of like, some kind of previous injury to the femur or all sorts of things. So go through these, identify the regional stuff. Any sort of imaging is high yield. So use that to your benefit. Obturator foramen is good because the innervation structures that go to your inner thigh comes from the obturator side. Okay. Now, disruption, any sort of damage to the capsular region of the femur, and I'm going to go over this. The Shenton's line is messed up, so you should have a nice kind of oblique line, and if that's gone, you have a capsular kind of damage. So you're going to see increased like X-ray density where bone is kind of displaced, or overlapping, less trochlear, more prominence, the external rotations, and all sorts of jazz. But if you guys can identify this damage, then you can start thinking of differentials as to anastomosis rep. Okay, this one is critical. I would star this and remember this. You guys need to know that you can have avascular necrosis via the reticular arteries that go to the head of the femur. right? Any sort of intracapsular damage, it's bad, right? You can have lower limb avascular events, bad, 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 okay? Anything below the intracapsular line with something like intertrochanter level or subtrochanter, obviously they can't put weight on their femur because it's the primary weight-bearing bone of your body. When you're walking, of course, you got to make sure that these are ruled out before you kind of go into the intracapsular, because these have very poor prognosis. Okay, you got to make sure you repair these quickly because avascular necrosis is bad in any level. Okay, now let's get to the knee. Okay, I kind of skipped over some of the musculature of the thigh because you guys have covered it today, and I want you guys to kind of sit with it a little bit more. Brady and Lindsay will cover it more with you guys next week or whenever they have their review session. So knee examination, okay? You guys got to know the lateral femoral condyle, the anterior tibial component is going to the ACL, right? ACL is just starting at the lateral femoral condyle, go to the anterior tibial portion. Whereas the medial femoral condyle to the posterior tibial is PCL, okay? And the mnemonic is LAMP, okay? This is a nice one from first aid. Keep that in mind, and it kind of helps you out with even the radiograph images. Let's do a question. Yeah, the lower limbs weren't as crazy of a yield because they really liked asking us in terms of like what's damaged. So if you remember the clinical signs, you're going to be typically okay. Instead of having to memorize the entire compartments, anterior versus posterior versus medial. So you guys are awesome. The tibial can be slightly displaced anteriorly because what is this called? The anterior drawer test, okay? So it's positive for the drawer test. So think of the drawer, you got to open the drawer to kind of test it. So that's why you move it anterior. So anterior drawer test. So what are you testing for? ACL, nice and simple, okay? Now, this is how they're going to ask your ACL versus PCL questions, okay? They're going to give you a radiograph image and they're going to tell you, is the ACL versus PCL, right? Whichever one it is, which drawer test or kind of your cruciate ligament kind of drawer test is going to be positive if it's an ACL tear versus PCL tear. Now, ACL, right? It starts at the femoral component, right here. It starts posteriorly and goes anteriorly and lodges itself at the tibia. Okay. Now, the PCL, just like before, starts posterior, right? And goes and attaches the posterior aspect of the tibia. So if you guys can remember that, you guys are going to be good in terms of imaging, right? How you can identify the ACL versus PCL. ACL, when you do the drawer test, it should move anterior, then that's a positive sign. If it moves posterior, then it's a positive sign for the PCL tear. Very simple, nothing too crazy in terms of forces that you apply. Okay, the crossing over is nicely outlined. Any questions?
Sorry. Yeah, I have a question. If what moves, the femur or the tibia? Or are you talking
The tibia.
about?
You move
Okay,
the tibia forward. Yeah, you move the tibia forward. You're going to try to move it, and if you feel resistance, that means the if you find resistance moving the tibia forward, basically the patient's going to be supine, their knees are going to be in an angle, and you're going to pull it forward, right? And if you feel resistance, their ACL is fine. If you completely can slide it out, that means your drawer test or the anterior drawer test is positive. So that means you have an ACL tear. If you move the tibia backwards, right? If you push it back and you feel resistance, that's going to tell you that the PCL is intact. If the tibia slides nice and easy back, that means PCL is definitely torn and you need to go in for surgery to get it repaired. Okay. Now, we're going to cover this one, and it's known as the unhappy triad. If you guys can identify it quickly. Okay, exactly, guys. It's the anterior cruciate ligament. Okay. Unhappy triad is a combination of presentation due to a what type of force acting on it? Is it a medial kind of impact or lateral impact? Where is the force being applied? Is it coming from the side, or is it coming from the inside of the knee? Lateral, exactly, guys. Okay, so what happens is you guys can memorize this: MCL, ACL, and medial meniscus versus lateral meniscus. This is like always the thing that people have issues with, whether it's medial versus lateral. Just remember M and M, and you should be good. MCL, ACL, and M, right? Medial meniscus. Okay. Important to know is that as this typically happens with football players, right? Like they're running, person tackles them in an awkward angle. Your medial collateral is likely torn, and the ACL also gets torn because of the way it's going, right? So you push and it snaps, right? It snaps these two, which is the medial collateral, and then the meniscus basically are these pads that stop the tibia and the femur from basically articulating together and basically, rubbing and destroying each other. So the meniscus act as a kind of a pad to make sure you don't, wear down your bones. Okay, and then the ACL, you guys know, it helps stabilize the knee joint because remember it's kind of a hinge joint by itself. Okay. Now the bursas, these weren't the highest yield, but it's important to know in general, the subcutaneous prepatellar bursa tends to be the housemaid's one because remember you're on the floor trying to clean. That's the housemaid, like you're leaning in more forward, so it's going to be the subcutaneous prepatellar bursa, right? That's right here. That's the housemaid's one. Whereas the subcutaneous infrapatellar, think of the clergyman praying on their knees, and how when you guys pray, whether at church or etc. You can basically imagine the position, the bursa that's basically anchoring it here. Basically, a bursa is just a pad filled with fluid to make sure that things move along properly and that impact and other things kind of don't get in the way. They're just filled with synovial fluid. Synovial fluid is just a mix of just different kind of water-like substance. It basically serves as a cushion and helps protect the knee from wear and tear. Okay, the Baker cyst, if they ever ask you guys this, I doubt because it's not as clinically relevant. It's located posteriorly, so the Baker cyst is like right here. Okay. Now let's do this question. We're almost done. You guys are troopers. It's almost 3 hours. I'm going to give you guys more time. This is definitely a challenge. So okay, we're a little split, I see, because these are tough. But you guys just need more time with this because you guys just probably covered it in lecture. So no big deal. You guys are correct. The answer is B, lateral femoral circumflex, because you need to know the division of the geniculate, right, of the popliteal geniculate division versus the descending arteries that are coming from like the femoral divisions. Okay, so we'll go over it. Important that you guys kind of keep this in mind. The 5 geniculate arteries of the popliteal artery are the superior medial, superior lateral, and then inferior medial and inferior lateral, and then the middle geniculate. That is coming directly from the popliteal. That's the one that's damaged and occluded and not giving proper blood supply. What gives you a division, right? The recurrent branch of the anterior tibial, as well as the 2 descending geniculate arteries, are coming from the femoral division as well as the lateral circumflex. And that lateral femoral circumflex is why we picked that answer. Okay. Nicely done, guys. Let's do this one. We're getting close to the end. I don't want to ask you guys things about the foot yet because you're going to cover it on Monday. And that would be just cruel and unusual punishment. And I ain't into that. It's just a tad bit more time. Okay, you guys are rocking it. So the answer is dorsiflexed and everted, okay? Result in which of the following, because we are looking at the leg compartments, we're basically saying the tibial nerve is damaged, right? And the tibial nerve gives off branches, right? But we'll kind of go over those. So what's going to likely be messed up? The tibial nerve right here. The tibial nerve is involved with doing the plantar flexion and inversion. So what we would see is the opposite of this, right? The posterior compartment is knocked out. So what's going to take over is these two. So what's going to result is dorsiflex and everted, right? A normal response, right, if everything was intact, would be the plantar flex and inverted kind of foot if the first two divisions were knocked out, which was the deep fibular nerve as well as the superficial fibular nerve. If these two are knocked out, you're going to have presentation based off of the actual compartment that's predominating, right? So you got to think of all of your musculature as kind of like a balance, a counterweight to each other, right? If one is doing something, the other is doing the opposite of that. That's why we call these an agonist versus antagonist, right? Muscle kind of groups. So anterior compartment is going to counteract the posterior compartment, as well as the lateral compartment has a role in that too. But you guys can kind of see how you guys can study these based off of kind of that principle, okay? I included this because you guys, it's really hard when they teach it to you to understand the divisions based off of like the broad overview. They really focus in on the compartments and they're like, learn it. And you're like, but I don't even know where it comes from. So the critical thing to remember is that the primary branches that are going to your legs are coming from the sciatic nerve, right? The sciatic nerve, when it gets close to the end of the femur, it gives off two branches, right? The first branch is going to become the tibial. I mean, it turns into the tibial nerve and then it turns into the common peroneal nerve. And the common peroneal nerve then further it gets divided into the common fibular. Then there's the deep fibular and then the superficial fibular that you guys see here. That's coming from the posterior side. So for example, let's say we've all been, kind of sitting on our ischium for too long, right? The common thing you're going to feel is like a tingling or kind of a numbness. That's because the sciatic nerve is compressed. So you're going to have issues with the leg, less so than with your thighs, because like your thighs are getting innervated by anterior structures that you guys are seeing with the femoral branches, the obturator, and all of that jazz. So understanding them based off of like anterior compartment and posterior compartment is great. But if you guys can put it into broader pictures, I think it helps a lot more than having to kind of like be like, oh yeah, anterior division's messed up, so the posterior division's doing this. Like it's quicker to kind of identify when you're first learning it, and then you guys can go based off of the anterior, posterior, lateral compartments, etc., so forth. Okay. Also, I'm priming you guys for how the innervation system kind of works for what you're going to cover Monday. So I included some information here. I'm not going to go over it because you guys haven't learned it. It's going to give you guys a heart attack, and I'm not into that. So we're just going to cover a couple of other random tidbits of information that you guys need to know, and then we'll kind of call it a day. Okay. Compartment syndrome. This is really important. It's a very buzzword heavy thing. They're going to have pain, paresthesia, pallor, paresis, pulselessness, and piclothermia. It's one of my favorite words to say for MSK was piclothermia. It just basically means they're going to have cold extremities. Why? Because what's essentially happened is that the the tibia is fractured. In that process, it's severed the vasculature that's running through that area. Let's say the patient's out in like some wilderness and they can't get surgical treatment. What you have to do is essentially cut through into the compartment and drain the blood, because the compartments in the legs, right, as well as the thighs, are essentially dense connective tissue. And you're going to learn more about the dense versus loose connective tissue and all that stuff couple of weeks later when you guys are getting closer to your exam, but it puts everything into context, and they're hard to basically drain blood. So you have to essentially incise and drain even in a non-sterile field. Otherwise, they're going to lose circulation, and they're going to basically die or lose their lower limbs. If things get bad enough, they could pass away. So compartment syndrome, 6 Ps, and it's a quick way to remember it, okay? Superficial incision, okay? Varicose veins, you guys are gonna cover this again in CPR, but it's basically when the valves, right? Think of your veins as basically the biggest storehouse of blood. But remember, blood goes to every single part of your extremities, right? And they have to come back to the heart so that they can get recirculated and eventually to the pulmonary circuit and all that jazz. But you guys got to think about varicose veins as basically like distended veins because the valves that are there basically fail. The muscular pumps kind of fail. So you're not going to get, you're going to have basically like dilated gigantic veins. So it's not pretty to look at, but it can be fixed to a certain degree. Okay. And then finally, dermatomes of the legs. As I tell you guys, dermatomes are going to be critical. You guys got to know all of these dermatomes. Okay. Constantly do flashcards or Anki with these, and they're going to help make your life so much more simpler. Because any sort of injury, reference pain can be falling along any of these dermatomal levels. Okay. And then finally, your reflexes. This is a really fun one to remember because they're based off of like kind of like I don't know, like the song like 1, 2, buckle my shoe, 2, 3, 4, kick the door, 5, 6, pick up sticks, 7, 8, lay them straight. And then like there's like additional ones like L1, L2 for testicular movement. That's the cremaster reflex that you guys learned with the genitofemoral branch versus ilioinguinal, which is the efferent limb. And then the anal winking that no one ever asks about that. But it's important ones. I pulled this from first aid. Yeah, there you guys go. And that being said, I included some external resources for you guys because I really found these to be really helpful. There are ones for lower limbs from CK Med, as well as ones for the abdominal thoracic walls as well that you guys can learn. Dr. Preddy's lectures, I've included. You guys have to just click this thing on your PowerPoints or your PDFs, and it'll take you directly to YouTube. So you don't even have to worry about the URL and stuff. External resources, as always, I included a whole bunch here. Obviously, our DES drives are really great. You guys can check them out. Scrubs, Dog Mom, and of course, my own. Here's the TPLG. Noted Anatomist is awesome. CK Med, Ingenuity, if you need an overall kind of drawing of everything. Armando Hasudigan is also really great. He does a lot of drawing. Ingenuity is more on the, he's not that great with anatomy because he just whiteboards it, and sometimes you just need to see like a straight up image, like a radiograph image. Okay. That being said, here's the link to the Facebook group. Feel free to join, and I want to wish you guys best of luck. I will see you guys potentially at the next weekend review session. And congratulations on making it to MSK. Big module, and you guys are going to do great.